and hence it is an easier approach for conduction system pacing because it gives almost same magnitude of benefit. So this is left bundle area anatomy. Now I am going in short. Left bundle consists of this left anterior fascicle, left posterior fascicle, and the common left bundle. And you can employ any of the region. Now, whenever we employ left bundle, then generally what we do, we initially locate the tricuspid annulus. If we put a
Hello.
temporary pacemaker, then it is. If we use a temporary pacemaker, then it is easier to locate tricuspid summit of the tricuspid annulus. And from tricuspid annulus, if we draw an imaginary line, then at 1/3 or at a distance of 1.5 centimeter, there is his bundle area. And in this area, you can search for his bundle, you can search for left bundle area pacing. So the area of left bundle area pacing is quite high and it is easier to locate. And left bundle area pacing means selective LVV pacing, selective conduction fascicular pacing, or it may be also left bundle septal pacing. So this is the consensus for CSP in EHRA. Here you can see that left bundle area pacing consists of left bundle pacing, selective, left fascicular pacing, or left LV septal pacing. So magnitude of benefit is almost same in all the pacing. So it is easier. Selective capture means capturing only the conduction system. Non-selective capture means capturing both the conduction tissue and the surroundings myocardium, and LV septal capture means capturing only the myocardium. And criteria for left bundle capture. Criteria for left bundle capture is mainly there is there is R wave in the V1, QR pattern in the V1, and along with this, the V6 RWPT should be less than 80 and V1 RWPT should be increased and V1 to V6 interpeak distance should be more than 33. So this has already been discussed. CSP indications in atrioventricular block. In atrioventricular block, the CSP, we generally prefer for non-selective CSP because if we have the benefit of ventricular capture, muscle capture, then it is easier for us and often there is less amount of threshold shifting. CSP indications for patient schedule for atrioventricular conduction block, and in this case you can see when the EF is in normal in less side, then it is always better to go for conduction system pacing 41 to 50, and in LVF greater than 50 you can go for RV pacing, but whenever there is EF is around 41 to 50, then you have to go for this CSP. And if LV is EF is around 40%, then you can go for biventricular pacing or CSP. But biventricular pacing is more preferred. In patients with 6 nodes, RV pacing must be minimized to avoid AF and heart failure. What about CSP? Implant atrial lead first and pace. Atrial pacing at high rest significantly lengthen PR and may even result in AV block. And implanting atrial lead first in patients with SND allows the evaluation of AV conduction to decide whether CSP may be useful or not. So, in sick sinus node syndrome, we can use atrial conduction system employment to reduce the number of RV pacing. And always RV pacing generally induce atrial fibrillation in this type of patients. Indications for CSP and CRT. In non-LVV cases, we can go for where LVEF is 36 to 50%. In those cases, CSP is useful, 36 to 50% of cases. If these cases are not typical indication for CRT, but we can use CSP in this type of cases. Okay, this is the lead, and generally here we can use Trendril STS spacing lead. Here it is FDA approved for LVAP, demonstrated LVAP success and safety, improved torque transmission to the helix with fewer rotation to the lead and body and compared to the lumenless lead, and robust distal lead tip design without a flexible zone that reduces the potential for distal fatigue failure, and zero helix restriction when used with the helix locking tool. One of the important thing that with tendril system, there is an helix locking tool which helps in the transmission of the torque. CSP locator they provide is another useful thing which helps us to locate the position of the CSP lead, and it helps along with this uh, locking tool, it helps us to locate the CSP tool at the position. The CSP locator 3D catheter is a fixed curve catheter with a both primary and secondary curve. The design of this CPS locator 3D catheter assists with the delivery and support of Altipace, LPA 1231 and Tendril STS pacing leads during LVA procedure. The primary curve allows crossing of the valve, while secondary curve helps guide towards a more septal location. So CPS location are of two diameter, 9F and 7F. And catheter hub includes a hemostatic seal and a side flush port that aligns with the proximal curve on the catheter. So maximum lead length are 58 centimeter and 65 centimeter. And the slitter is one good one, and this is the Agilis His Pro slitter.
Dr. Kundu, I think we have another couple of minutes left.
Okay. Now this is LVAT. This is one of the important concept. Here you can see LVAT is basically the difference between the pacing stimulus and the uh, PRS and the QRS uprising pattern. And here you can see in these two ECG, in the down one, the LVAT is short. This is one. Sorry. Sorry, can you on? Just a minute. And this is the idea of selective capture, non-selective capture, and the LV septal capture. In LV septal capture, only the
You are showing something, no?
yes, yes. LV septal capture, only the myocardial capture is important. In non-selective capture, both myocardial and the conduction system is important. Conduction system is captured, and in selective capture, only the conduction system is captured. And ROA peak time is also important. Here you can see the V1 peak time and V6 peak time. This is the difference. is important. This is V6 minus V1 peak time. This is important. V6 is used as a surrogate for activation of delay of the lateral wall. V1 is used to reflect RV activation. So I am not going to this lab overview and procedural consideration. Okay, two things I just just
30 seconds more.
okay. In lateral view, I should aim for 90 degree of the lead, and in RAO view, it should point towards 2 o'clock position. And whenever I put the lead, it should first point W pattern in when it is on the right side, W pattern in V1, discordance in 2 and 3, and AVR AVL discordance. And then gradually, as I screw through, then the notch should move backwards and the Q should become prominent, and the V6 RWPT should be less than 80 milliseconds. So these are the steps of advancement. And another important thing is the current of injury we should measure. If the current of injury drops down sharply, then there is
Can we
chance
go
of
to your summary,
perforation.
the final slide?
Perforation, and there is fixation bead. Okay, so just we should, in summary, we should put the lead in LAO view and RAO view. RAO view, it should point out towards 2 o'clock position. First, we should look for W pattern, and then we should start screwing. And as we screw forward, there is appearance of R wave, and then we should look for V6 RWPT and V1 RWPT, and the difference between V6 and V1 RWPT to see whether it is getting selective or non-selective. Thank you.
Thank you, Dr. Supradeep. Sorry that
We
we
had to cut
are
short,
very in short of time. It was a nice thing, but it was very detailed, and we are sorry that we have to interrupt you. So we will call our next speaker, Dr. Kuntal Bhattacharya.
Dr. Kuntal Bhattacharya does not need any introduction to this city. He is one of the most dynamic young cardiologists of our Tagore Hospital. And just a small story. I mean, I think Kuntal might be mentioning that too. Regarding the development of ICD, Dr. Mirowski in 1966 was traveling with his friend up in escalator from the cafeteria after the lunch. And in the cafeteria, his friend had a cardiac arrest and he could not do anything to save him. By the time the lift reached the top, his friend was dead. So that was the beginning of the thought that if this man had a device in him, he could have been shocked and that man could have been survived. And this was in 1966. With the subsequent researches of dog ICDs, finally the first implant took place in
complete cessation of the cardiac activity as well as the respiratory activity. And by 1 hour period of time, if it is not intervened with proper measures, there will be biological death, and it is an irreversible thing. So the pre-existing heart disease probably is the most common cause, but there are some causes where there is nothing previously documented. So sudden cardiac death happens, and often there is some prodrome which we ignore. Usually we ignore. So sometimes we have atypical chest pain, some palpitation like of symptoms, some shortness of breathing on exertion on or fatigability, and it often preceded by some presyncopal sign of symptom or some abnormal fluttering kind of movement, and soon the patient develops VTVF or asystole. So that is a very horrible thing. And if you are guided by automated defibrillator nearby and some CPR is available, probably the life can be saved, otherwise you will die. So if you see, there are variants of sudden factor is also variable, and based on the age, there are higher predisposing factor. In younger age, the predisposing factor are different, and the elderly there are different. So in young patients, suppose the patients are between 35 to 40 years or 50 years, Probably the most common cause is coronary artery disease, that is acute MI situation. And in elderly, probably it is a dilated cardiomyopathy or other risk factor or valvular heart disease in advanced stage. Some young patients may have genetic cardiomyopathy or genetic channelopathy like Brugada syndrome, then RV dysplasia, long QT syndrome, etc. The another very important person who are very active is hypertrophic cardiomyopathy. They often die suddenly during their exercise or sport activity. So if you see the more than 35 years old patient, the major percent is coronary artery disease, and 80% patient die of sudden cardiac death because of occlusive MI. So heart attack and sudden cardiac death is not same. Heart attack is when there is sudden cessation of blood supply because of coronary artery occlusion and it causes MI. MI may precipitate sudden cardiac death in some cases, but sudden cardiac death is not equivalent to heart attack. Now, the initiation of therapy and identification, whether the patient is having VTVF is very important. So it is a very important data from Swedish registry, where almost 2,800 patients were studied. And if you see the intervention time, so the x-axis is in minutes and the survival chance is in percentage. So if the patient is intervened within 2 minutes, the survival chance is 50%. Whereas below and beyond 10 minutes, the survival chance is very thin and it is only less than 2 to 5%. So it is very important slice it. So major cause is VTVF, tachyarrhythmia, and few cases asystole is also there. So I've already discussed, I'm not going. So the risk factor and the predisposing factor is very important, and the young patients are dying because we have to cut down all these things. So if you have a strong family history, you have to go for a routine checkup at a periodic interval, probably as soon as age 30 for Asian patients. You have to cut down your smoking. The blood pressure and diabetes has to be well controlled. Many Asian patients is having bad cholesterol, so this dyslipidemia has to be taken care of, and probably taking statin at early age will causes rate sudden cardiac death by reducing the plaque burden and the plaque gets stabilized. So this is very important. Obesity and obstructive sleep apnea is very important. Alcohol and alcohol binge is also important, that we have seen in that Assamese singer. Okay, and the lifestyle modification, the sleep deprivation, the abnormal timing of sleeping and awakening cycle. So most of these IT people are now working in American time, so they are doing night shifts and they are taking rest in the morning shifts. So this is very important. There are some risk factor like electrolyte imbalance, CKD patients. So these are the identifier, and we can check who are the high risk patient. We can take appropriate action. So symptom is something no symptoms, and there is sudden collapse is the first symptom. So here you can see this is a very active person who is doing gym, and during gym this lady is 35-year-old lady suddenly collapsed. So only the CPR and automated external defibrillator probably save him. Automated external defibrillator is automatically charged and automatically discharged by you have to just attach the pedal. It will automatically dictate what to do, when to stop CPR, when to start CPR, and by commanding you can do the thing, and that is the lifesaver. But training for CPR training is very important in most of the population, like school teacher, uh, non-cardiac physicians in hospital. The CPR training is very important. And how it works. So whenever the ventricular fibrillation starts, you can see this cartoon, the right panel. It shows there is suddenly multiple discharges from ventricle without any effective contraction. So ultimately, the patient will die because of VF. Now, prevention is primary prevention that I already discussed. The primary prevention of sudden cardiac death for high-risk patient, you would identify the high-risk patient, low ejection fraction, prior MI, uh, with ejection fraction of less than 35%, dilated cardiomyopathy with end-stage heart failure, patient who are waiting for cardiac transplant, they are actually high-risk patient, and for those patients, ICD therapy is beneficial. And some group of patients who are already suffered a sudden cardiac arrest, who are resuscitated by some defibrillation, and when there is no reversible cause, like sometimes there is hyperkalemia, hypokalemia, or electrolyte imbalance, so these patients are also candidate for ICD therapy. So indication of ICD therapy in primary prevention is low ejection fraction, post MI, after 6 weeks when the ejection fraction is less than 35%, and sometimes we find some NSVT in the Holter, and These patients are high-risk patient, probably young patient. A 75-year-old patient with ejection fraction 30%, I will not advise AICD. But a young patient, MI, EF is not improving even after guideline-directed therapy, I will probably advise ICD. There are several trials has established both in primary and secondary prevention. So this is the defibrillator machine. This is external defibrillator machine, both manual and automated. Automated is common base, nothing to do, just fix your patch, check your battery, it will do its job. And there will be no charge or discharge if patient is having asystole. So it will also detect, but most of the automated external defibrillator don't have simultaneous monitoring where you can see the rhythm. External defibrillator manual, you have seen everywhere. All doctors who are going for a routine treadmill test always check whether that center is having TMT, because there are so many centers nowadays they are doing TMT. I have seen many patients are dying because of VT with high risk of coronary artery disease patient during TMT. So if the defibrillator is not working in that center, don't go for TMT. This way the ICD works. This way the ICD works. This is a sinus rhythm. Whenever the rhythm changes to VT or VF, it identifies the rhythm, and if it is VT, it gives a anti-tachycardia pacing therapy initially 2 to 3 cycle. If it fails, then it discharges with a high volume shock. You know, this shock amount is only 15 to 35 joules when it is deployed internally, but externally usually 100 to 200 joule is given. The 200 joule current is equivalent to 2000 volt of discharge in 1 millisecond or 2 millisecond period of time, because your thoracic impedance is very high. Your thoracic impedance is 100 ohms. So to surpass that, the entire myocardium you have to depolarize simultaneously. So it is very high voltage. It is a 2000 volt. So can you imagine? So this is the ICD previous generation when there was 2 coil were used. So you can see this is like a pacemaker, a little bit bigger device. Now the Gallant Abbott has come up with Gallant device. It is a Bluetooth enabled device, and you can see like pacemaker lead, but there is some coil. These coil are actually shock delivery.
Kuntal, kindly.
Thank you, sir. This is my last slide. So this is a young child who had VT, but he has CHB. So therapy is pacemaker. So take home message is primary prevention of SCD in high risk patient plays major role. ICD is most cost effective if you identify the patient who are at higher risk, and probably availability of the CPR team and availability of the AED is helpful in major part like airport, hotel, restaurant, school, college, etc. We can prevent sudden cardiac death. All the gyms should have AED and CPR trained team. So thank you, sir.
Full job. And I think all of us in the hall would be leaving with the knowledge that what is a leadless pacemaker and its benefits over the wired pacemakers. We would now know that what are the disadvantages of a conventional pacing, and how to overcome these disadvantages by using conduction system pacing. And thirdly, we would know, all of us have now our concepts clear about what is a certain cardiac death and how can the primary prevention, the secondary prevention, and when to put an ICD and what an ICD really does. So I think all the 3 speakers have done a wonderful job, and we need to give them an ovation. Sammy.
So we come to the end of the first session from Wires to Waves, and I'll be requesting this chairperson, Dr. Alok Mojumdar and Dr. Nataraj Basappa, he's presently not here, and Mishra, Dr. Shub Pratip Kundu and Dr. Kuntal Bhattacharya to kindly move on to the memento corner for receiving their mementos. Any more time? I think we are running a little late. We will be starting from insulin to incretins, the injection of diabetes. The chairperson, Dr. S. Mukhopadhyay and Dr. Indira Jha. They need no special introduction to this hospital. They are associated with hospital for a very long time. And the first speaker, Dr. Ipshita Ghosh, I request to kindly come onto the stage.
Thank you and welcome to this session from insulin to incretins, the injectable journey of diabetes. And we have the age-old insulin with us, which are serving for 100 years. And we have also the magic molecule of recent advance, that is a GLP-1 receptor with us. So how to combine, and when not to combine, all the things will be discussed in this session. Our first session is when and how to combine a GLP-1 receptor agonist with insulin, critical pearls and pitfalls. And the speaker is Dr. Deepshita Ghosh. Please project her CV slide once. Not mine. Dr. Deepshita Ghosh's CV slide. Okay, if it is not there, Dr. Deepshita Ghosh is a very bright and young endocrinologist, very good orator, and she is presently attached to the RKM hospital as associate professor, assistant professor. So, Dr. Deepshita Ghosh, please.
Thank you for this invite, and it's an honor to be a part of the 50th Foundation Day of B.R. Singh Hospital. An interesting topic because GLP-1 receptor agonist is creating all the noises nowadays, and that is why it is very important to know when and how to use GLP-1 receptor. And again, insulin being an age-old treatment, but still we are quite skeptical when we are using it because of the risk of hypoglycemia and pinpricks. That is the reason why when and how to use is very important for us. So with this, I would start with that around 63% of Indian population are suffering from diabetes, which is not controlled, and out of which 66% is actually obese, and around 21% of the population coming to us with micro or macrovascular complications at the time of diagnosis. So that is a big problem for us. So why do we wait for sequential therapy or stepwise therapy? We should achieve an early and sustainable glycemic control by adding drugs together. So that is what we are now doing in our clinical practice, that combining medications for further treatment. So this is the unmet need. What are the unmet needs for diabetes control is something which is very important when we start a insulin. Basal insulin needs to be started when the HbA1c is more than 9% and patient is having osmotic symptoms. But and also if patient is more than 3 OADs or medications, and after which the HbA1c is not under control, this is where we start an insulin. To avoid multiple pricks, we start with usually a basal insulin. If the sugar levels are still under not control, so we increase the dose to a basal bolus or a premixed insulin. But now we are having a GLP-1 receptor agonist which actually works on the PP sugar. So a basal insulin that is working on the fasting sugar and GLP-1 receptor agonist working on the PP sugar will create wonder. So the GLP-1 receptor agonists that we have, except for one, all are injectable. So why do we prick 2 or 3 times? It is better we go for a combination also. So we have got a combination therapy as well. So if I have to talk about what are the reasons behind not to give these medications, is that possibly the pinpricks. So fear of hypoglycemia, the inertia that we have, that is for the physician as well as the patient themselves. Physician has the thought that possibly the fear of hypoglycemia, the weight gain possibilities with insulin are the hindrance behind putting these patients on insulin, and the complexity of the insulin therapies as well. And on the other hand, the patient also has that feeling that the fear of injection, the hypoglycemia, weight gain, complexities, physical quality of life can GLP-1 receptor agonist with insulin. So combining basal insulin with GLP-1 receptor agonist, we have two in the market. We had two in the market, Zutolphi, which was marketed by Novo, has been called off, but the only one which is available is Foliqua, which is liximatide with Glargine U100, which is approved in India and 70 other countries. So why do we use so? Because it acts on multiple aspects of diabetes, pathophysiological defect of diabetes. So we attain glycemic control early and sustainable, thus delaying the progress of the disease and delaying the progress of the complications, improving the quality of life, improving the cost effectiveness of the therapy. Now, as I already mentioned, basal insulin reduces the fasting sugar. The reason behind that is reducing the gluconeogenesis from the hepatic gluconeogenesis. And on the other hand, GLP-1 receptor agonist has got an effect on the glucagon secretion, also delays gastric emptying and thus reduces the postprandial excursion. So one affecting the fasting, the other PP. So if I have to look into the ominous octet, 7 out of the 8 ominous octet is being addressed to by a single drug. That is an insulin and a GLP-1 receptor agonist. But the only thing that is left out is the action of SGLT2 inhibitor, which is only done by the SGLT2 inhibitor by the kidneys, on the kidneys. So it's an effective glycemic control with these two together used, the lesser amount of side effect if used with as monotherapy, and huge amount of glycemic benefit, and the macrovascular and the microvascular complications are also reduced and delayed. So what are the guideline indications or recommendations? So 2025 ADA is of the opinion that we should start with the combination therapy if and when required rather than waiting for stepwise therapy. Even the ACE 2023 and the EASD 2022, they are all talking on the same terms that recommends early combination therapy rather than waiting for the sugar levels to go haywire and then start on a combination therapy. So these are all the guidelines that we are talking about, but I'm not going to go into details of this. And why do we use a combination? Because a single injection, obviously, the cost effectiveness is improved. GLP-1 is getting the benefit of GLP-1 receptor agonist and insulin, lesser amount of hypoglycemia, lesser amount of side effect, which is caused by a GLP-1 receptor agonist when used as monotherapy. The weight gain caused by insulin can be reduced with the GLP-1 receptor agonist. So what are the evidence that we have? We have 5 studies in which 3 of them has been done on patients who were suboptimally controlled on insulin and 2 of them which were suboptimally controlled on medications. So Lixilan L study, which was done on patients who were on a long-acting insulin, whether it was Detamir, NPH, or Glargine, for more than 3 months and on medications. They were put into 2 groups. One was on Iglar Lixi, that is what I'm talking about, and the other was on only Glargine insulin along with metformin. So after 30 weeks of the study, around 0.5% HbA1c reduction was there. SMPG or the 7-point values were also on the lower side, and around 60 milligram per deciliter reduction in the PP was seen, which similar setup, similar baseline characters, which half of the patients were put on Iglar Lixi, the other was put on premixed insulin. The patients were looked after 26 weeks, and after that we see what we are seeing is the primary endpoint of those percentage of patients achieving a goal of HbA1c less than 7% without hypoglycemia, without weight gain. The percentage of patients, the HbA1c reduction that we see from the baseline, and the fasting sugar reduction as well. Along with that, the side effect profile were looked into. So if I go through the details, then the HbA1c reduction was not that huge, but was by 0.2, which was again superior. And the weight gain effect was also there. Around 2 kg the weight difference was there between the two group. Obviously, the person who is getting premixed insulin was on gaining weight by 2 kgs. And the secondary endpoint showed that around 42% of the population were getting an HbA1c reduction to less than 7%, of which without hypoglycemia was around 27%, and without hypoglycemia and body weight gain was around 19.4%. And the total daily requirement of insulin was also less with the group using Iglar Lixi, which was around 12 units more for premixed insulin. Incidence of hypoglycemia was also less by 45 to 55%, and again, nocturnal hypoglycemia was less by around 65%. So obviously, it's a safe, effective and a very useful combination, and obviously cost effective when we are using two together. So this is a solid switch study in which the patient was already on premixed insulin with OADs, and these patients were switched to Iglar Lixi. So patients were already on premixed insulin, and the first 12 weeks, the patient were titrated every 3 days, and later on the titration was reduced to once a week. And after 24 weeks, we saw that the HbA1c reduction was actually huge, of 1.5%. And the dose reduction that was done was by 20%. So if uh, premix insulin, the total dose was around 24 or more than 25, we were using around 20 units of Iglar Lixi. So there also, there was a huge reduction
Shita,
in...
will you wrap up?
Sure. So there was a huge reduction in the sugar level, and it was highly effective as well. The fasting sugar level was reduced by 60, and the PP was around 70 milligram per deciliter. Solid was mainly on medication on which the patient were put on Iglar Lixi, and the other group was on IDEC aspart. The baseline characters were same, and what we saw was that the HbA1c reduction was also higher in the Iglar Lixi group. Again, the 7-point SMPG was also lower with the Iglar Lixi group, and weight gain was also less with the Iglar Lixi group. Obviously, hypoglycemia was also less. So as a whole, I would say, I won't go through the next study. This is the pen that we use, in which we use it on the basis of the insulin dose. So this is I would just go with the pitfalls, because I've already discussed the importance of the therapy already. And so pitfalls, the dosing schedule, it has to be taken 1 hour prior to a meal that we are taking. So if we miss once, we have to take it another 1 hour earlier to the next meal that we are taking. That needs to be fixed, number one. The the dosing that we need to do, the titration, has to be fixed with the fasting or the insulin level. So we can't go on increasing the only the lixisenatide portion, but we have to increase only the glargine portion. In such a way, the Iglar Lixi the lixisenatide will also increase. So PP control, if further is required, we have to add another drug. And maximal dose is also limited. We can't go huge increase in the dose. And obviously, the cost is another effect. So with this, I'll be ending my talk. So thank you for this invite.
Thank you, Dr. Ripshita, for your elaborate and informative deliberation. So please be seated, as the time is short. I think I will hand over the mic.
Thank you, Shormishta. A very good morning to all the delegates. And next, I would like to call upon Dr. Selima S. Taktarenia for the second session on insulin. She will be speaking on in-hospital insulin therapy in critical care. Doctor, to you.
A very good morning, everyone. At the very outset, I would like to thank the entire organizing committee of IRHS and Shurmishta ma'am for this opportunity. I have been entrusted to speak on in-hospital insulin therapy in critical care unit. So whenever we are talking about hyperglycemia in an in-hospital setting, what is the definition? Usually, as per the American Diabetic Association, we consider a blood glucose greater than 140 to be the definition of hyperglycemia in a hospital setup. The HbA1c goals, rather the HbA1c cutoff still remains same, that is 6.5%. Now, any patient who has been admitted to the hospital can either be a case of already known diabetes, or who has been diagnosed with diabetes for the first time during admission, or a case of stress-induced hyperglycemia, and differentiating them is also equally important. Now, what are the glycemic targets? There have been several studies, trials, and a lot of data in literature, but there is a common consensus that if the patient is critically ill, then the glycemic target should be about 140 to 180 mg per dl. And if the patient is non-critically ill, then the targets can be a little more stringent. That is, the lower limits can be set off to about 100 to the upper limit of 180 mg per dl. Just a little bit of data regarding effect of hyperglycemia on hospital mortality. So here again, we have a lot of contrasting studies. There have been a lot of studies in the past which have shown that very strong blood glucose control is going to lead to better outcomes in the surgical setting, medical setting, lesser mortality, early rate of discharges, better wound healing. But then some other studies have contradicted this by showing that stringent glycemic control can lead to hypoglycemia, which again can be a contributor of mortality. So then again, there have been other studies which have suggested that we need not go for very strict control, but we can have an average range of about 140 to 180. So these are all the data. In view of time, I wouldn't be going through all of it. Now, coming to the glycemic perturbations that we face in an ICU setting, why do we get hyperglycemia, hypoglycemia, variable sugars? That is because whenever a patient is admitted in such kind of a setup, he or she can be exposed to IV dextrose, parenteral nutrition, there is persistent bed rest, there can be overfeeding, there is release of stress hormones, that is counter-regulatory hormones which lead to increase in blood sugars like cortisol, epinephrine, etc. Certain medications, for instance, the use of exogenous glucocorticoids, which we very commonly find in our day-to-day practice as well as in the ICU setup also. So these are reasons which lead to hyperglycemia. We can also get hypoglycemia in the other end. For instance, if the patient is having severe sepsis, trauma, there has been a glucocorticoid use, but it has been withdrawn, if there is cardiovascular failure, etc. So now coming to why is it that we need to use insulin? That is because we have some trouble that we face while using the oral anti-diabetic agents. For instance, metformin. It is a very commonly used drug, but it can lead to lactic acidosis in some patients, those who are having a kidney injury, sepsis, hypoxia, shock, because this is a very common setting in the critical care illness. Secondly, if there is a iodinated contrast imaging procedure in patients with reduced EGFR, there also we need to be cautious. If the patient is having a history of liver disease, alcoholism, acute heart failure, so there are a lot of factors which are related with this, and we need to keep in mind, and it's always better to be on the safe side. Secondly, coming to sulfonylureas, which are very commonly used, but then they predispose the patient to hypoglycemia, particularly if the patient is on the older side of age, if there is a concurrent treatment with insulin, if there is renal impairment, etc. Coming to thiazolidinediones, the usage are being reduced because there's a slower onset of action. They lead to edema, contraindicated in heart failure. Coming to SGLT2 inhibitors, which have been known to have a lot of cardiac benefits, renal benefits, inpatient use increases the risk of euglycemic diabetic ketoacidosis. There is also an increase in risk of genitourinary infections, for which the use of SGLT2 inhibitors is not recommended. Coming to GLP-1 receptor analogs, which are a boom in the market these days, but they also have a lot of increased GI side effects, and the data regarding their usage in terms of glycemic control in the ICU, we still need more research on that. Now, coming to in-hospital setting, so basically critical care and non-critical care, we cannot really demarcate them, or we cannot really bring in a barrier between, okay, this patient belongs to critical care, this belongs to non-critical care, because it is a very dynamic state. Today, a patient who is admitted in the ICU, tomorrow maybe gradually he's improving and he's being shifted to the ward. There might be a particular patient in the ward who, but then suddenly he deteriorates and he or she has to be shifted to the ITU. So basically, it is a continuum state, and we need to keep in mind as in what is the entire scenario while handling the sugars of the patient. So what is the mode of insulin delivery in a patient who is in a critical care setting? So if we look at the subcutaneous mode that we commonly use for a day-to-day patient, there is inconsistent absorption, because if the patient is in a shock stage, there is poor perfusion. If there's edema, it's difficult. And also sometimes what happens, this variable or rapidly changing insulin requirements, it's very difficult to meet by the subcutaneous route. So if the patient is in a critical care setting, then the mode of insulin delivery is intravenous. Now, how do we start an IV infusion? Usually the choice of insulin is a regular insulin. We can also use short-acting analogs, but they do not have any additional advantage. So 40 units of regular insulin are to be taken in 39 ml of 0.9% normal saline. That is, it should come down to about 1 unit per ml. The initial rate of insulin infusion is the current CBG divided by 100. For instance, if the patient is having a CBG of 400, then we divide it 400 by 100, which comes to 4 units per hour. And the CBG needs to be monitored hourly. The dose needs to be adjusted till a target of 140 to 180 mg per DL is achieved. Now, once 2 consecutive readings are within target, we need to monitor the CBG 2 to 3 hourly. Potassium also needs to be monitored. Now, how do we maintain the insulin infusion? We should always check regularly for whether there is any blockage or disconnection of the pump. If there is a resource constraint setting, then we can administer 25 units of regular insulin in a 500 ml 0.9% NS, and then it can be delivered through an IV drip set. Now, coming to the adjusting of the infusion rate, so this again depends upon the setting. If the CBG level of decrease is greater than 30 mg per dl in an hour, we can continue the same dose. If it is lesser than 30 mg per dl, then we can increase the dose. And if it is continuously above the initial value, we can go on increasing. What we need to address here is that if the CBG is less than 70, irrespective of whatever was the prior value, we need to hold the insulin and administer 25% dextrose. If the CBG is between 70 to 90 mg per dl, then also we need to hold the insulin, but we need to check the CBG initially half hourly till we reach 90 mg per dl, and then we need to check it 1 hourly till the CBG increases to greater than 140. Once it's greater than 140, we need to start it at the 50% of the previous rate. Say, for instance, if a patient has come to us with an initial CBG of 500, we divide it by 100, we start with a 5 units per hour, and say, for instance, that patient, the CBG has slowly gradually come to in between 70 to 90. So then we're going to stop it, we're going to monitor it half hourly. Once it increases to greater than 140, we'll restart with the half of the previous dose, that is about 2 to 2.5 units per hour. So I have just kept this image in case anyone is interested, we can discuss later. Now, the most important question, sliding scale. So I'm sure all of us must have commonly encountered, whether it's a government practice or it is in consultation in a private setup, regarding sliding scale, which is very frequently used. But it is something that we do not recommend because it fails to incorporate the basal insulin requirements. We cannot titrate it in the right way, and it is a retrospective approach of blood glucose. Instead of preventing the sugar spikes, rather it aims at bringing the sugar levels down once it's high. So something that we are not desiring, and it's also a roller coaster phenomenon. So this is something that we do not recommend. Now, say for instance, the patient who started with a CBG of 500 is now almost stable. When do we think of switching from the intravenous to the subcutaneous insulin? What are the prerequisites? If the patient is hemodynamically stable, the patient is having a stable infusion rate in the last 6 to 8 hours, if the patient's blood glucose level is also stable, say it's about less than 180 to 200 for at least last 4 to 6 hours, and there is a stable nutritional plan. In this scenario, we can plan to switch or shift the patient from intravenous to subcutaneous insulin. Now, how do we go? How do we decide on what would be the dose and how would be the differentiation, or rather the division of the dose? So total daily dose is calculated. This is based on the last 24-hour insulin requirement in the form of infusion. So if the patient was requiring, say for instance, 40 units or 50 units in the last 24 hours, we need to take 80% of that as the total daily dose. In another way, what we can do is, if the 24 hours data is not available due to some reason, we can take the last 6 hours insulin requirement and multiply it by 4 to get the total daily dose, and then we calculate 80% of it. Now, whatever we have calculated, that has to be divided into 2 parts, either a basal or it has to be divided into 50% as basal and 50% as bolus insulin. So this is one way of doing it. Another is when we decide on this, I'll just take one more minute, ma'am. When we decide about the subcutaneous administration, it should include basal and bolus. So the bolus can also be calculated on the basis of insulin to carbohydrate ratio, as in how much unit of bolus dose is going to bring about how much reduction in the carbohydrates, that is, it's going to handle how much grams of carbohydrates. And another is a correctional insulin, that is, if you have an excess of sugar levels, how much extra insulin is needed to bring it down. So this is it. And coming to the monitoring, patients who are not having any history of diabetes, we need to monitor for 1 to 2 days, and the ones who are having, we need to monitor it a little further. Those patients who are on clear fluids, we only give the basal administration, we do not give the bolus. Those patients who are on Ryle's tube feeding or bolus tube feeding, we give both the basal as well as the bolus. Now I'll directly come to the takeaways. So insulin is the preferred therapy Basal bolus regimen is always preferred. Glycemic targets in critically ill, it's 140 to 180, and it's non-critically ill. The pre-meal is less than 140 and random is less than 180. In special situations like nil per mouth, we use basal plus correctional insulin, and we need to avoid long-acting sulfonylureas. Coming to monitoring, glucose checks before meals, bedtime, 4 to 6 hourly. If the blood glucose is less than 70 mg per dl, then we need to immediately administer 25% dextrose. And the discharge regimen as well as the inpatient needs need to be aligned. Thank you very much for your patient hearing. And if there are any questions, we can take.
Thank you, Dr. Silima. As we are a little running late, so we won't be taking the questions here. We can discuss later with you. And that was a very elaborative and very nice presentation. So what we learned was that in a critical ill situation, we need to have a stricter, not such a strict control. You can go from 140 to 180 milligram. And the rest you spoke very well. Thank you.
Thank you, our chairpersons and our speakers. I'll request them to please go to the memento area and get their mementos. So without wasting any more time, we'll move on to the next session, that is an oration, Dr. S.C. Kundu Memorial Oration. And our chairperson is Dr. Alok Majumdar, and our speaker will be Dr. Ajay Gautam. I'll ask them to come to the stage. May I have the slide of Dr. S.C. Kundu Memorial? And I'll request Dr. Alok Majumdar to formally give the Medal of Oration to Dr. Ajay Gautam before he starts his speech. Yes, we have. Actually, we are doing a video better than the photographs, you know. So, Ajay, please.
Before Ajay starts, I just add a few things. When I joined this hospital in 1989, BR Singh Hospital had already become an iconic center providing top-class cardiological services to the city. This hospital, under the stewardship of Dr. S.C. Kundu, under whose name the oration is there, Dr. T.D. Bhattacharya and Dr. Roxy Senior had already established this hospital as a center of excellence. In those days, BR Singh Hospital was the first hospital amongst the government setup to start a dedicated ICCU 5-bedded with central monitoring and recording, which was inaugurated by Dr. Mr. Madhu Dandavate in 1978. Subsequently, with an attached lab to do temporary pacing. We had, during those days, the second echocardiography machine of the city. We were the first center to start IV thrombolytics, urokinase, which was given to a politician's father, non-railway person here. Subsequently, we became the first center to start pacemakers in the form of cardiologists doing transvenous pacing by Seldinger method. We incorporated nuclear cardiology, and thereafter, our center, although it was a top-class center, the need for intervention cardiology and in-house cardiac surgery was increasing. And in 2011, we came up with an advanced cardiac center inaugurated then by Mrs. Mamta Banerjee virtually, being the second center in whole of Indian Railways 40 years after the first center. So I now request Ajay to go ahead and discuss about the advanced cardiac center of BR Singh Hospital.
Thank you so much. Good morning to all. Respected dignitaries, distinguished guests, seniors, chairperson, sir, and colleagues. Can you guess what exactly it means? Okay, So this is classical Mr. Shashi Tharoor's jargon, which simply means avoid confusion, remove unnecessary word, and speak clearly. That is what exactly I am going to do. So my topic would be recent advances in cardiac management and updated cardiac facilities at BR Singh Hospital. And I will not at all to be Mr. Tharoor. So it can be of two groups. One is medications and another is intervention or surgery. So if we talk about medications, heart failure management has come up very nicely recently, and there are medications: ARNI, vericiguat, SGLT2 inhibitor, omecamtiv. In HOCM, there is a new drug, mavacamten, which will be launched very soon as an antihypertensive drug, cilnidipine, felodipine, ARNI, aprocitentan, and as an anti-angina drug, we all know ivabradine, nicorandil, and ranolazine. Antilipidemic drug, inclisiran, making a lot of buzz, and it has come up like anything. Now, if we talk about cardiac intervention, which is TAVR, transcatheter-based aortic valve replacement, mitra clip, device, CRTD, ICD, leadless pacemaker, CSP pacing, we have already discussed it, and IVL, IVUS assisted angioplasty, rotablation assisted angioplasty, EP study, 3D ablation of PSVT pathways, and atrial fibrillation, pulmonary vein isolation. In cardiac surgeries, MICS, minimal invasive cardiac surgeries, robot assisted surgeries, and AI assisted, and of course, heart transplant. So this is TAVR or TAVI, which is a catheter base. You can see there is a balloon mounted valve which is placed in aortic position, and recently we have self-expanding valve also. So it is very convenient, especially in elderly fragile lady who are not candidate for surgery. They are very well going for this procedure and doing well. This is mitra clip for mitral regurgitation. This is also catheter based, and it's a kind of cinching method, just clip like method, which is done by intervention cardiologist. This is Watchman device. It is a device is placed in atrial appendage in persons who have recurrent thromboembolic episode because of clot formation, and it is very effective in people who have recurrent issues despite anticoagulation. So these procedures exclusively were with CTVS surgeons, and of course our CTVS surgeon friends are very upset with cardiologists because most of the things are taken up by we cardiologists. Now it's a very interesting slide to see. This slide shows the pacemaker development right from 1950s when it was AC powered pacemaker, and it was huge with an extension cord. In 1950s, it was transistorized wearable pacemaker. In 1958, first fully implantable pacemaker was available. In 2015, the classical pacemaker came. In 2016, leadless pacemaker also came. And in future, of course, we can get batteryless devices which harvest cardiac motion to power pacing circuits. This is the leadless pacemaker we have already discussed, a very small device, and in complicated cases where this lead, this is CRTD, left side you can see CRT, especially implanted in patient with severe LV dysfunction. So it has improved, and it has been seen if it's a right candidate, overall cardiac function also improves, and quality of life and mortality benefit is also there. On the right side, it's ICD implantation, which prevents sudden cardiac death. This is basically intracoronary imaging. On left side, you can see it's OCT, optical coherence tomography, which shows a angioplasty patient of LAD, and very nicely demonstrated in the lower part the good apposition of stent. On the right side, it's a right coronary artery, and the character of the lesion is shown. By IVUS, we can see the character, their calcium, and how length exactly we need. So by this two imaging, we can get good idea of the plaque burden, good idea of the lesion, and finally we can do the intervention with more accuracy, and outcome is also very good. This is MICS. The classical incision was very long incision central. With now MICS surgery, the scar is very minimal and very effective, and early mobilization is possible. In our setup, as early as possible, if patient can be discharged, so manpower loss, man days loss will be less and less. On right side, you can see the robotic surgery, and it has come up in India also, and even the operator can operate from a distance place. So this is the advantage of this robotic surgery. Now I will come to the updated cardiac facilities at B.R. Singh Hospital. As Dr. Alok sir has already explained, B.R. Singh Hospital has always been an iconic hospital of the city, and cardiac treatment facility has been available for almost 50 years, with cardiac ICU set up in 1977, first in the city with centralized monitor and a lab for temporary pacemaker implantation. This hospital also had the first pacemaker implantation in the Kolkata city, and first hospital in the city to have echocardiography machine. And students from medical colleges used to come to this hospital for training. Now, Advanced Cardiac Center with state-of-the-art facility came up in 2011. Dr. Alok Majumdar sir, Dr. Basudev sir is here. They have huge contribution in establishment of this Advanced Cardiac Center. This now, from 2015 to 2025, I joined in 2015, and this 2011 and 2025, there was a huge paradigm shift. These are the stalwarts of cardiology department of B.R. Singh, Dr. S.C. Kundu, of course, Dr. T.D. Bhattacharya, Dr. Alok sir, Dr. Basudev sir. So from 2011 to 2025, there was a huge paradigm shift once Advanced Cardiac Center was established. And now in 2025, I'm very proud to say that this center is one of the most advanced cardiac center in the whole eastern part of the India. So this is a collage of important occasions. The first angioplasty, which was done in 2011. First CABG on 12th May 2012. Initial cath lab team, the team after getting Best Department Award in 2017. And recently, we did a first ASD device closure in a pediatric age group, which was only 11-year boy, and it was very successful. Patient is doing well. And we did also first MICS surgery in 2024 of 17-year girl. It was fantastic experience, and the girls and the parents were very happy to get this treatment. And finally, she is doing well. Now I will show you simple slides. This is a LED artery left side, and after stenting, there is TIMI-3 flow, good improvement. On right side is a device which is CRT therapy. You can see 3 leads. Leadless pacemaker on left side. On right side, dual chamber pacemaker. ASD device on left side. This is the classical ASD device implantation method. This is a case of our hospital. It was a 21-year-old boy. On the right side, we did our first aortic stent implantation of a severely aortic aneurysm patient. He was a patient 50s from Jamalpur. He had a huge thoracic abdominal aortic aneurysm, and he was very symptomatic. So we did our first ever successfully. He is doing fantastic, and he has no complaints at present. Recently, in September 2025, we also have installed our OCT machine, and we did our first OCT-assisted angioplasty successfully. So, to give you overview of our department, we have a lot of facility, state-of-the-art facility in our hospital, cardiology department. We do angiography, coronaries as well as peripheral, angioplasty, BMV, pacemaker, ICD, CRT implantation, EP study, rotablation, ASD, VSD, PDA device closure, IVUS, OCT, rotablation, FFR, IVL, TEVAR, CABG, valve replacement, congenital heart disease, and MICS. And I'm very proud to say we have done more than 12,000 cardiac interventions till now, more than 1,800 CTVS surgeries, more than 6,500 pacemaker implant, 600 special procedures, and many more. So what is the future plan now? Of course, leadless pacemaker we are going to do in near future. We have already procured one. TAVR and or TAVI we have planned. Mitra clip, Watchman device, why not? More MICS procedure we would like to do. Pediatric, we have planned to start pediatric CTVS surgery also. And why not cardiac transplant? Of course, if feasibility will be there, we will always try our level best to do the most advanced cardiac transplant also. With this, I would like to stop my speech. I again really thank all the organizers and all the audience for patient hearing. Thank you. Thank you so much.
Thank you, Ajay, for a wonderful walk down the memory lane, bringing us the recent developments of the Advanced Cardiac Center that has come up. I feel very proud that I have left the baton in good hands. In 2020, when I left it with you and Basudev Bhattacharya, and now you. Now, a small untold story. When Dr. Munnadas left us, uh, having been with us for about 2.5 years, suddenly myself and Dr. Vasudev Bhattacharya were left alone. I mean, it was impossible for us to handle the entire load. I was desperately looking around for someone who's completed his DM or DNB. I came to know there was one boy from Southeastern Railway doing DNB cardiology in Apollo. I went to Apollo, met his mentor, Dr. Ravin Chakraborty, who's been a close friend of mine, took his file, took consent from him, went to Railway Board, myself, met Dr. Budlakoti, who was the then DGRHS, and Dr. Amitav Datta was the ED Health at that time, and convinced him the need of having a DM cardiology is more here than in Southeastern Railway at that moment. And even before the Southeastern Railway people knew anything about it, an order was issued in the name that Dr. Ajay Gautam, after completion of his studies, to join in Eastern Railway. However, Southeastern Railway did take it not very smoothly. Ajay was finding it very difficult to get the release.
Very difficult to switch over from
release.
Southeastern to Eastern
I
Railway.
went to CPO, I met the CMD, and I met GM personally. And then, as a senior DMO, I was going around. And finally, we could get Ajay's release from Southeastern Railway, and he joined us in 2015. Thank you so much.
Thank you. Thank you so much. Ma'am, so right now, as an IRHS officer, I am the only cardiologist here. Dr. Basudev sir is still here as a senior consultant. One CMP cardiologist, Dr. Arindam Mitra, is with us. He is a very good young dynamic cardiologist. And one IRHS doctor who is MD medicine and very keen to go for cardiology, he is also with us, Dr. Arnav.
We close this session, Dr. Esikundu oration, and I'll be requesting the chairpersons and the speaker to kindly move on to the memento corner for receiving mementos. The next item, Dr. Ira Ghosh oration. Will laparoscopic surgery replace open surgery? The chairperson, Dr. Amitabu Mukhopadhyay, is a very senior and renowned senior consultant in obstetrics and gynecology, and he has had the privilege of being associated with B.R. Singh Hospital for over 2 decades as a visiting consultant. I'll request Dr. Amitabu Mukhopadhyay to kindly come on to stage. And the speaker, he also needs no introduction to B.R. Singh Hospital, a pioneer in introducing gynecological laparoscopy in this hospital. I hand over the proceedings to Dr. Amitabu Mukhopadhyay.
A very good morning to all of you. This is a very honorable lecture, Dr. Ira Ghosh Memorial Oration, and details of Dr. Ira Ghosh. I have to read it. You can see in the slide. And this lecture will be delivered by Dr. Shubhra Datta. He is the present consultant obstetrician and gynecologist in this hospital. His designation is Additional Chief Health Director. He is DNB coordinator. I know Shubhra for a very long time because I was associated with this hospital as a visiting consultant for nearly 20 years. And Shubhra is basically pioneer to start laparoscopic surgery in this hospital, and he has gone a long way. Without wasting time, I think I shall request Shubhra Datta to start his lecture, and before that, I'll give him the oration.
I'll request our chairperson to present the medal, Ira Ghosh Oration Medal, to Dr. Shubhra Kanti Datta.
Dear delegates, friends, and teachers, today we are going to discuss something that many of us has been thinking about. Actually, we are a set of doctors, some of us, at least I think most of us, who started our learning in medicine, surgery, gynae in the last century and is practicing and are practicing it in this century. So we have seen a lot of transition in the modes of treatments, the ways of surgeries that are being done. In our student days or in our internship, house surgeonship, or PGship, we have seen little bit of laparoscopic surgery. Everybody will be remembering the single puncture laparoscope for doing bilateral tubal ligations. We were amazed to see that that can be done in within, some people were doing it within minutes. But there were complications too, there were fatalities too. There were tearing of the tubes, there were emergency laparotomies being done after that. But gradually things improved, the optics improved, the thermal energies, the energies that we use for the laparoscopic surgeries improved. And we also have passed through the stages of development of laparoscopic surgeries. So let me go through the slides. This is just an introductory slide. Surgical techniques have evolved, as I am telling, from the traditional open procedure to minimally invasive laparoscopic methods. This presentation compares laparoscopic and open surgery in terms of approach, outcomes, and patient care. But sometimes this minimal access surgeries, at least in older days, was accompanied with maximum complications. Laparoscopic surgery, as you all know, that the minimal invasive approach using small incisions, a camera, and a specialized instrument. Open surgery, traditional approach involving large incision, directly visualizing, and the access of the surgical site. And the most important thing that we have not yet been able to overcome in laparoscopic surgery is in open surgery, we can use our fingers. We can feel the tissues. We can do perfect dissection. And also we can use, as we were told in our student days, that the fingers are the best retractors that you have. So those things we cannot use in laparoscopic surgery. One should not forget it. Advantages of laparoscopic surgeries, as you all know: smaller incision, less postoperative pain, shorter hospital stay, faster recovery, reduced blood loss, reduced infection, better cosmetic outcome, earlier return to normal activities. And the advantages of open surgeries: direct visualization, access to the organs, easier handling of complex and emergency cases. This is very important. In emergency, when the patient is, say, pulseless, such as in the case of ruptured ectopic, There is a debate whether we should go for a laparoscopic ectopic surgery or for an open one. There's still a debate. Requires a less expensive equipment suitable for patients with extensive additions and contradictions of laparoscopy. The disadvantages of each approach: laparoscopy requires advanced equipments and expertise, which we are being able to get in most of the hospitals. Initially, even say 10-15 years back in medical colleges, where the students start learning the basics, there were no laparoscopic instruments, laparoscopic cameras, only basic instruments were there. But nowadays, most of the medical colleges are equipped with top of the line laparoscopic sets, and all the professors and associate professors who have come up were trained in laparoscopic surgery. So the PGTs, the house surgeons, are also being exposed to laparoscopic surgery. Longer operative time in some cases, it depends upon the person who is doing it, depends upon the type of case that we are doing. The risk of trocar injury, yes, carbon dioxide complications, gradually decreasing as we are getting more trained, as we are getting more accustomed to this sort of surgeries. Open surgeries, large scars, higher infection rates, longer hospital stay, recovery, more postoperative pain. These are true. But all depends on the surgeon. If the surgeon is more skilled with open surgeries than the laparoscopic surgery, then the patient is safer, I think, when he is doing an open surgery. The clinical outcomes: multiple studies show that a faster recovery and a reduced postoperative complication with laparoscopy. Long-term outcomes are often comparable between both the methods. Choice depends upon the patient factors, disease complexity, and the surgical expertise. The last thing I think is the most important thing. As I was saying that in medical colleges, gradually everything is being done laparoscopically. Most of the things are being done laparoscopically. The flip side of this is that our students, the young doctors, are not learning about the open surgical techniques. We are the fortunate ones who had been exposed to the open surgery and now the laparoscopic surgery. I personally feel that you should have a very good knowledge about open surgeries, very good knowledge of the anatomy before you jump to the laparoscopic surgery. But nowadays the training has reversed. Most of the persons, most of the surgeons, I think the young surgeons, they can do laparoscopic cholecystectomy, but open cholecystectomy they will hesitate. So this thing should be kept in mind. One should not jump from the very beginning on laparoscopic surgeries. One should be well trained in the standard treatment protocols, standard surgical procedures. Then they should venture into the laparoscopic ones. Laparoscopy is definitely a good one for the patients, but you should train yourself before you embark on it. So now I am going to give you some glimpses of the surgeries that we have done over the past, say, 2 decades. And you can see, you will be able to see from the slides that how we have advanced from very minor surgeries, say from diagnostic labs, then tubal dye tests, then ligations, then ovarian cysts. Like that way, we are gradually in. So this is the first thing that I want to say. An 18-year-old girl came with a history of pain lower abdomen, USG level left ovarian cyst. So left ovarian cystectomy was planned. You can see from the slide, it was very done very long ago, maybe say 20 years back. So we found a bicarbonate uterus with dermoid cyst. This is the things you can see, the hairs coming out. This being put inside a bag before retrieval. The outcome was excellent, and we were fascinated. Another case is the intramural uterine fibroid. We never thought that we will be able to do a myomectomy with a proper suturing and no blood loss, but little blood loss with laparoscope. But we could do it. 30-year-old patient with 1 child came with a complaint of pain, lower abdomen and menorrhagia. USG revealed large anterior wall fibroid, 8 centimeters. Lap myomectomy was planned. This is the fibroid, old picture. This is the fibroid being taken out with the help of a myoma screw. This is the suturing that we have done, intracorporeal suture. That was a very unique thing to be done at that time. Maybe it was done 15 years back. And the tissue is being retrieved by morcellation. And this is the tissue we can see in the kidney dish that we have removed. It was quite a large fibroid, and the patient had a good recovery. Another thing, gradually we are advancing. You can see broad ligament fibroids. Normally, say 15 years back, we wouldn't have dared to do it laparoscopically. We would have converted to open hysterectomy. But in this case, we dared. And this is the broad ligament fibroid. You can see. This is the broad ligament fibroid enucleated. And this is the specimen that we have taken out. You can see the fibroid is more than the size of the uterus. This is a very recent case that we have come across. The patient, aged 31-year-old, came to our OPD with a complaint of passage of blood through urine during the time of menstruation, since the birth of a last child by normal vaginal delivery. The patient had her first child by normal vaginal delivery 12 years ago, which was uneventful. She had a second child by LSCS 10 years ago, which was also uneventful. She had a last child by normal vaginal delivery 4 years back. After the delivery, she suffered severe sepsis and was admitted to ICU for 8 days. Now we had a intuition that this is a case of uterofistula. Methylene dye was pushed into the uterus through the HSG cannula and the cannula, and was seen that the dye is coming through the catheter placed inside the bladder. We did also this urographene was pushed through HSG cannula, and you can see the blood is coming inside the urinary bladder. Cystoscopy revealed a defect in the posterior superior wall of the bladder. MRI pelvis was done and appeared to be a communication between the posterior wall of the urinary bladder and the uterus. So we decided that we will try laparoscopically to fix this problem. This is the pictorial representation of this fistula between the uterus and the bladder. Initially, the bladder peritoneum was lifted and separated from the anterior uterine wall. The bladder wall being separated from the anterior wall of the uterus. You can see both the fistulas, the bladder fistula above and the uterine fistula below. The first layer of the bladder suturing was done. Second layer of the bladder suturing was done. The bladder suturing completed, the uterine fistula is being sutured. The uterine fistula suturing is also completed. So you see that gradually we have advanced. It is not a very easy thing. It is a long learning curve. Now we feel that we can do most of the surgeries laparoscopically. Some of the very good laparoscopic surgeons, they do all sorts of surgeries, even radical hysterectomies very nicely. As a matter of fact, better than open surgeries. But it depends on the quality, on the training, on the expertise of the surgeon. So to conclude, both laparoscopic and the open surgeries have their indications and limitations. Laparoscopic surgery is preferred for its minimally invasive nature, but open surgery remains essential for certain cases. Understanding both the techniques is crucial for the development of surgical judgment and patient-centered care. Thank you very much.
Thank you, Dr. Shubhra Datta, for your wonderful deliberation on this subject. Now, any questions from the
take questions, but actually
from the audience?
We are running short of time.
Okay.
We are lagging behind about 5 minutes or so. So I think if there are any questions, we can discuss later on.
Okay. So I will conclude this session with few sayings from my side. As Shubhra Datta has already mentioned, that laparoscopic surgery is picking up, and the type of surgeries he has shown, you can understand that very complicated gynecological procedures can be done by laparoscopy. Practically, there is no surgery nowadays which cannot be done by laparoscopy in gynecology. But the question is training and expertise. These two are very important things which should be kept in mind, and Foremost, as he has already mentioned, that conventional surgical skill is absolutely necessary before you proceed for laparoscopic surgery. And you should be conversant with both types of surgical skill. And with these few words, I would like to conclude this session. I thank the organizers for inviting me to chair this session. Thank you.
I would like to thank the sponsor, Messrs. Medtronic India Limited, and I'll request our chairperson and speaker to kindly move on to the memento corner for receiving their mementos. The next session, Emergency in Rheumatology. The chairperson, Dr. Aniruddha Kittonia, previous Principal Chief Medical Director, Eastern Railway. He needs no introduction to this hospital as well as this zone. A very versatile and competent orthopedic surgeon with a keen interest in hand surgery. I'll request him to chair this session, Emergency in Rheumatology. And the speaker, Dr. Shorbani Sengupta.
Good morning to all of you. Our Dr. Shorbani Sengupta needs no introduction. He is one of the, I have encountered one of the best Indian Railway health doctor now and previously also. Such a versatile and such a tender and great clinician. Indian Railway is very proud to have such doctor, and she is delivering her lecture on emergency rheumatology. As we all know that rheumatology is usually a chronic problem, but there are lots of emergency problem as well. And Dr. Shorbani Sengupta is the best person to deliver it this topic on this session. Over to Dr. Sengupta.
Thank you, respected chairperson, for your kind words. And a very good afternoon to all the dignitaries present here in this auditorium, and my chairperson, Dr. Aniruddha Kittonia, our ex-CMD. Now, my topic is emergencies in rheumatology practices. So emergencies in rheumatology practices, it encompasses urgent situations involving the joints and beyond joint issues like systemic disorders, requiring immediate intervention to prevent morbidity and mortality. Now, there are several key emergencies which may arise out of all rheumatological disorders, but due to paucity of time, it is not possible to describe all of them. So I will just highlight a few which we come across in our day-to-day rheumatology practices. Now, we all know that rheumatoid arthritis is one of the common disease which affects which is a multisystem autoimmune disease. Here, with the background of rheumatoid arthritis, we find one sudden morning, if a patient presents with a single joint red hot swelling and with constitutional symptoms like fever, we have to put a needle in the joint and make the diagnosis instantly, which will show more than 50,000 of neutrophils and low glucose with a positive culture of either strepto or staph. And we instantly know the diagnosis is septic arthritis in the background of rheumatoid arthritis. So we all know that with the high antibiotic support, we have to irrigate or drain the fluid. Now, next, a person who comes with acute onset of loss of vision, and she may complain of progressive bluish discoloration of the sclera, and ultimately one day the sclera gives in. That is a painless one, but an ocular emergency. This is called scleromalacia perforans. and it needs immediate surgery by the ophthalmologists. Another rheumatoid patient who is having acute pain abdomen and neurological deterioration one day lands in the emergency, and the CT scan immediately done shows a mesenteric ischemia, and they are suggestive of some nervous system vasculitis. This is rheumatoid vasculitis, which may be acute and critical condition which a patient of rheumatoid arthritis may face, and these are the extra-articular manifestations. The acute emergency may arise from mesenteric vasculitis, neurological involvement like meningitis-like symptoms, mononeuritis multiplex, or acute stroke. They may be also associated with palpable purpura or ulcerations. This is one of the unique situation a rheumatoid arthritis patient may present with. A long-standing rheumatoid sufferer may complain of neck pain and progressive weakness of all four limbs. And on clinical examination, a spastic quadriplegia was detected. And on imaging, it has been found that on extension and flexion X-rays, it shows that more than 3 millimeter in adults and more than 5 millimeter in children, it is always an indication of atlantoaxial dislocation. And of course, more than 8 millimeter difference between the atlas and the odontoid process needs immediate surgery. Another dreadful disease, rheumatological disease, which is a systemic lupus erythematosus. It is an autoimmune and multisystem disease, affects almost all the vital organs of the body. So a young woman who presents with all the features of lupus may suddenly develop proteinuria or hematuria, and the renal biopsy confirms a diffuse proliferative lupus nephritis. This is a really emergency for a young person necessitating renal replacement therapy. So kidney involvement is much more commoner, and also the other system involvement in which the lungs is the next, starting from any acute bacterial infection to life-threatening diffuse alveolar hemorrhage, and ultimately this is shrinking lung syndrome with ILD, which may be a very dreadful and life-threatening situation necessitating ventilation. Systemic lupus patients may also land into the emergency with acute abdomen. Most commoner are acute pancreatitis, and on CT scan, you also may get this halo or target sign, which immediately points towards lupus enteritis. Now, neuropsychiatric manifestation. This is very important because often missed. Starting from acute psychosis, seizure, or acute stroke, or septic meningitis like a presentation, they may come in the emergency and get admitted. And on MRI or imaging, they may show demyelination, which may also mimic like multiple sclerosis. Hematological emergencies, patient may attend emergency with a severe massive bleeding due to severe thrombocytopenia. There may be autoimmune hemolytic anemia causing severe anemia, and the most dreadful condition, hematological condition, is thrombotic thrombocytopenia purpura, which may be life-threatening. This unique condition is called antiphospholipid syndrome. Mostly affects the young person or young woman. They have two prongs. One is the obstetric prong, which one affects recurrent spontaneous abortions, particularly in the second or third trimester of the pregnancy, or stillbirth, or even hypertensive disorders like preeclampsia or eclampsia. And the next one is the thrombotic APS. We get many patients, young patients, both male and female, admitted in our wards with pulmonary embolism and hepatic vein thrombosis. And in OPDs, we get many patients with DVT and with the background of antiphospholipid syndrome. Now, the most important and catastrophic one is this catastrophic APS, which we call CAPS. This is involvement of 3 or more vital organs within a very short period of time, that is within 7 days, and ultimately leads to a life-threatening acute critical condition unless they are detected early and treated early with anticoagulation. Now, painful hands. Many patients of systemic sclerosis comes to us with painful hand due to the Raynaud's phenomena. But what is most critical is that acute ischemia may cause amputation. Now, patients got admitted in with hemoptysis or blood in sputum. Now, a middle-aged man having hemoptysis and gets admitted with petechial rashes all over the limbs and body. On examination, we find rals in both lungs. And here you see the X-ray shows fluffy opacities in both field, and that is suggestive of diffuse alveolar hemorrhage. This is a really life-threatening situation in case of systemic vasculitis. Now, when this pulmonary involvement is combined with rapidly progressive glomerulonephritis, and this is called pulmonary renal syndrome. This is a unique situation which needs immediate attention and life-saving measures like ventilation or renal replacement therapy like dialysis. Acute visual loss, a patient, elderly patient may attend the ophthalmology ward or ophthalmology OPD with acute vision loss. There you have to suspect giant cell arteritis or temporal arteritis. Nowadays, the ultrasonography of the temporal artery gives a typical halo, which is definite sign of temporal arteritis. It needs immediate attention. Now, this is inflammatory myopathy. This is one of my patient presented to me with this heliotrope rash around the eyes and Gauthron's papule over the hand. And the patient complains of proximal myopathy. This is typically polymyositis, dermatomyositis. But what is important and life-threatening situation behind it is that a presence of malignancy. One have to suspect when this type of patient comes to you, you have to exclude some form of malignancy behind. And as usual, on investigation, this patient had colonic cancer. Now, the neonates are also not spared from these emergencies of the rheumatological diseases, because if a person or a mother with a strong or active lupus with a strong antibody positive, Rho and La positive, may give birth to a neonate who having these rashes, but moreover having a complete heart block necessitating emergency placemaker. Now, juvenile idiopathic arthritis, apart from acute uveitis, the most important and life-threatening situation is macrophage activation syndrome. A young child or a young person presenting with PUO and having all the features of macrophage activation syndrome, and the bone marrow shows these hemophagocytes, is really a life-threatening situation necessitating immune suppressive therapy as well as high dose of steroid. Last but not the least is acute low back pain. Any person may present with this acute low back pain at any age, and the causes may be multiple, from mechanical cause to inflammatory cause, infective cause, neoplasm. This is very important. One has to keep in mind about bone mates. But what is most important is one has to look for the red flag signs. I've shown here there's few of the red flag signs. These are very important, and you should look for these red flag signs. I will not go into the detail of management because it depends on the background nature of the disease. So coming to the conclusion, rheumatological emergencies includes a spectrum of acute life-threatening conditions necessitating the prompt recognition, multidisciplinary management, and tailored therapeutic intervention. Thank you so much. I acknowledge Dr. Anamitro Haith, who has helped me to prepare the slides. Thank you.
Thank you, Dr. Sharvani Sengupta, for your lucid presentation. All the topics has been discussed, and we all, though rheumatological emergencies are not very common, but we always have that clinical insight because it affects from neonates to the elderly, from eyes to kidneys, lungs, and whatnot. So the clinical insight and red flag signs always to be kept in mind. We should avoid these life-threatening emergencies like CAFs and mass and all others, we always keep in mind. Thank you very much.
Thank you. I'll request our chairperson and Shorbaridi to move to the memento section and receive their mementos. So we move on to the next session. Very interesting session. The speaker is none other than our budding neurologist, Dr. Novendu Jana, and our chairpersons are Dr. Shorbani Sengupta and Dr. Nilendu Chakraborty. I'll request the chairpersons to take their seats and Novendu to come to the dais. The topic is recent advances in migraine management. Nilendu?
A very good morning to all the dignitaries.
So I have to play a new role here and chair a session of a very young, dynamic neurologist who has joined again with the super specialty in BR Singh Hospital, and he is Dr. Navendu Jana. So as we all know that migraine is a headache, which is a throbbing and pulsatile headache. Those who have experienced migraine, they only know it is not only a headache, but it also disturbs the whole body, whole system, the person and the family. So I'm sure that Dr. Jana will give you a real insight and updated management of this headache, which is really a headache for all. And thank you. We welcome Navendu to start the session.
Thank you, ma'am. I'll not waste much time and start. I'll just ask the audience members to please scan this QR code through the Google cameras. This will come across when the presentation is on. I'll just ask all the audience, please scan the QR code which is on screen. We'll get a questionnaire and we'll be discussing this case in midst of my presentation. It will come again. There is no issue with that. So coming, as Shorbani ma'am had already told us, that migraine headache is one of the most common problems that not only neurologists, but all the general practitioners across streams come across. So the discussion points today, we will be discussing in brief about the definition and classification of headaches and migraine, the burden of the disease in global epidemiology as well as the Indian epidemiology, the symptoms and diagnosis of migraine, the pharmacological management of migraine, and the limitations of the armamentarium that we have at this point of time, and the newer innovations that are coming up as far as migraine diagnosis as well as treatment is concerned. Now, coming to classification first, very broadly speaking, I'll not go into the nuances of headache, otherwise it will become very difficult for everyone to understand. But the basic thing about headache is when the emergency or when in the OPD, we try to differentiate it, whether it is a primary headache or a secondary headache. Primary headaches are the migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headache disorders. The secondary headaches, which we need to actually really recognize in the emergency or the OPD, are when it is attributed to trauma or any injury, when it is attributed to cranial and cervical vascular disorders, and maybe also due to another non-vascular intracranial disorders. There is a mnemonic, and this is an accepted mnemonic in neurology known as SNOOP. Whenever a patient is coming with systemic signs and disorders, when there are other neurological disorders associated with headache, when the headache is sudden, new onset, and the pattern of the headache has changed, and when your patient is coming with a headache for the first time, when he or she is above 50 years of age, when the onset is thunderclap presentation, that means within a minute, the patient tells that I have had the worst headache of my lifetime. and when the headache is associated with papilledema, pulsatile tinnitus, positional provocation, and precipitated by exercise. Whenever any component of SNOOP is present in your patient, always do an imaging. The only take-home message from this slide is all headaches are not migraines, all headaches are not primary headaches. We need to understand which is the secondary headache. So remember the mnemonic SNOOP. Whenever you are getting such a patient with these manifestations, always go for an imaging and rule out the secondary causes. Now coming to migraine, we in the hall almost know what migraine is. Migraine, firstly, that we all need to understand is, and make our patients also understand, that it is a clinical diagnosis and there are no biomarkers or no imaging really shows that this patient has a migraine and not any other headache. The common symptoms include photophobia, phonophobia, nausea. The patients also experience vertigo and dizziness. The frequency and severity of migraine, it fluctuates between the patients in the same patient as well. These are the various stages. Not all patients really have these prodromal phase or the aura phases. Rather, now epidemiologically it is seen that migraine without aura is more common than migraine with aura. Now coming to a very important slide, that what is the disease burden? It is said to be the second highest cause of global disability in the general population, but first amongst the women in the reproductive age group. The first one being low back pain. So migraine is 3 times more prevalent in women than men, and that is why whenever a neurologist comes across a patient who is a female and is in her reproductive age group, we need to be very careful, because prophylaxis, the acute medications, they can all hinder with her menstrual hygiene. Coming to the disease burden in India, it is almost as in the global ones. We have almost 12.84 crores which are affected every year, and the males are not very far behind, almost 8.54 crores almost in every year. In 6 studies, the prevalence has ranged from 14% to 30%. As I was talking, that we need to always dedicate a slide about migraine and its impact in women during the key life stages. Actually, the thing is, it's all about the oxytocin and the low and estrogen. When these hormone fluctuations can trigger migraine, and they can also protect against migraine attacks. As you can see, that the one which is marked in red, when you are having low estrogen and low oxytocin, there is increased CGRP signaling, which increases the propensity of having migraine. And that is why females, especially during their menstrual cycles, which we call as catamenial migraine, they have those tendencies of having a migraine, especially in the first 2 days of their menstrual cycle. This gradually, when it goes beyond 50, the hormonal balances, they come to a balance, and that is why we often do not get patients, especially female, beyond 50 who are migrainous. And that is why, coming to my first slide also, that whenever a female is coming with an intense headache to your clinic who is above 50, do not think of migraine, think of other secondary causes, because migraine pathologically should not happen to a lady after she is 50. Now coming to migraine triggers, I think this is also known to almost everyone. The pathological triggers are hormonal changes that we just talked about. Stress, thought is said to be one of the most common trigger. Attacks often occur during the let down period, means depression is often seen with migraine. Diet, hunger and fasting can trigger attacks. Common food triggers include alcohol, cheese, chocolate, excess caffeine intake or caffeine cessation. Just keep this in mind, even caffeine cessation can cause migraine as well. So if you're drinking coffee and your doctor tells you that do not drink coffee, it may exacerbate your migraine, sudden stoppage of drinking coffee also can precipitate attacks. Medications, overuse of birth control pills. That is why I'm always repeating that catamenial migraine and migraine in the reproductive age group is very important. Sensory stimulation, people with migraine are more sensitive to the external stimulus, such as lights, sounds, and odors. The common symptoms during a migraine attack, this is also, I think everyone in the hall knows about it, can actually involve any part of the headache, of the head, though it is classically taught that it is generally unilateral, usually moderate to severe in intensity. It's often throbbing and aggravated by physical activity. These 2 points actually differentiate it from the tension type headache. which is actually the most common type of headache epidemiologically. Other symptoms during headache is hyperosmia, olfactophobia, and cutaneous allodynia. Diagnosing migraine, the take home message again here is it is a clinical diagnosis. If your patient is uh, insisting on a imaging or other diagnostic measures, make him or her understand that it's a clinical diagnosis and do not really press on for an MRI brain, which has become a very fashionable thing to do, especially for the young females. So my advice or my take home message to the audience will be, do not go for brain imaging when you are really sure that it is a migraine and not a secondary headache. Now, importance of patient history. The thing that we need to understand is migraine always has a very strong family history. Always ask whether the first degree relatives of the patient had a history of migraine or not. Diagnosing migraine without aura, basically it's diagnosed in patients with 5 attacks fulfilling the following criteria. The headache should last for at least 4 hours. The maximum is 72 hours and has to have at least 2 of the following. Predominantly, it should be on one side, moderate to severe intensity, aggravated or can be caused by avoidance of physical routine activity, and has a throbbing quality. In addition to these, it may be associated with nausea, vomiting, sensitivity to light, photophobia, and sound. ICHD 3, actually, we are coming up with ICHD 4 also. Now, coming to unmet needs. What I have come across in my very short career as a neurologist and in general medicine, I think that migraine is, in some clinics, it is undertreated. In some clinics, it is overtreated. So both the spectrum is there. Though I have mentioned in my slide that it is undertreated, but there are physicians who treat normal headache patients also as migraine and put them on prophylaxis. So the patients who need prophylaxis, I'll be coming across the slides later on. So this also has to be kept in mind, that always give the patient prophylaxis when it is needed and the rescue medications on SOS basis. I'll skip this one. Now coming to the newer modalities of migraine treatment. The recent pathophysiology of migraine has showed that CGRP, the calcitonin gene-related peptide, plays a very important role in migraine pathophysiology. So as you can see, that triptans and argots, the sumatriptans and the rizatriptans that we often prescribe, they prevent CGRP release through the 5-HT1D receptors. Lasmitidine, which had got approval only a few years back, also prevents CGRP release. Anti-CGRP receptor monoclonal antibodies, erenumumab, this is available in India. Botulinum toxin is also used for treating refractory migraines. Anti-CGRP ligand monoclonal antibodies, they are also in India now. CGRP receptor antagonists, rimegepant, ubrogepant, zivegepant, we have rimegepant now in India. It has been approved for acute treatment, and definitely the NSAIDs, which prevent the neurogenic inflammation. So has the audience really, oh, they have already given the answers. So I'll just tell the history. It's about a 21-year-old medical student with exams round the corner and nursing a recent heartbreak, who presented with a headache and nasal congestion. It was a history which was typical of migraine. So the diagnosis is not in question. He tells the emergency doctor on duty that he is allergic to paracetamol. What rescue medications do you offer him? So 33% of the audience have voted for sumatriptan. Naproxen and domperidone, 14% has given nimesulide as well. No one wants to give diclofenac. Well, in the government setups, diclofenac is more readily available. He was a government college student. So he was actually given the diclofenac initially, but unfortunately, he showed allergy to diclofenac as well. Then he was given naproxen and domperidone. He had allergy to it as well. Sumatriptan was definitely not available in our government college emergencies. So the last resort was nimesulide. And he responded to nimesulide. So the next question is, I think no one has gone to the next question. Oh, please scan it. Why do you think that he was rescued by nimesulide? It's changing, no issues with that. Why do you think that he was rescued by nimesulide without any adverse effect? Please do not give options for the question 1. Stick to question 2. Why do you think that he was rescued by nimesulide without any adverse effects? Okay, I'll just tell the options. He had never tried nimesulide before, and hence sensitization was not there. Nimesulide is a weak COX-1 inhibitor and a preferential COX-2 inhibitor. Nimesulide is structurally unrelated to other NSAIDs, and nimesulide inhibits leukotriene synthesis and prevents hypersensitivity. Please do not give answers to the first question, otherwise it will disturb the presentation. Anyone, the PGTs? Are there anyone in the halls? Why do you think that he was rescued by nimesulide, which is also an NSAID, but he did not have any of the side effects that was there with paracetamol? I'll tell the answer. Actually, nimesulide is a weak COX-1 inhibitor and it's a preferential COX-2 inhibitor. It was seen that when that patient was given etoricoxib, he did not have any allergies. Literature says that COX-1 inhibitor allergy is far more common than having a COX-2 inhibitor. And that is why he was put on nimesulide and his rescue medication became nimesulide. However, if this patient comes to your clinic and where finances is not a constraint, then the answer would be sumatriptan. Now, 14 years down the lane, he himself is now a neurologist, is now on 3 prophylactic medications, propranolol long-acting 40, topiramate 50, and valproate CR 300. However, there is minimum benefit. He is still having headaches with a picture of medication overuse headache as well, because he is taking more than 15 to 20 nimesulides almost a month. So what should he do now? Continue the same prophylaxis and try other rescue medications, because we all know that nimesulide is not a very good drug to be on. Okay, continue the same prophylaxis, taper down prophylaxis and question the diagnosis. Okay, try newer agents such as lasmiditan and rimegepant. No one wants to try newer agents. And taper down prophylaxis and questioning the diagnosis. So we have 50-50 here. Well, he did try non-pharmacological interventions. Nerivio is a band which is worn over the shoulder and the arm. It targets the trigeminal nucleus. However, Nerivio did not help him. Continue the same prophylaxis and try other rescue medications. Okay. The correct answer here is newer agents such as lasmiditan and rimegepant. Okay. So coming down to what was our main topic, the acute episodes, we have already said that these are the drugs that are available in the armamentarium. It is triptans, but however, rimegepant is one of the drugs which is really taking over the triptans because of its less side effects, and triptans have a big problem with vasoconstriction, right, which is why it cannot be given to cardiac patients. That is why rimegepant has come up like anything in the Western literature. It has already been improved in India as well, but only as a rescue medications. It is not very far off that rimegepant will be approved for prophylactic management as well. This is the reason that it inhibits vasodilation without active vasoconstriction. It inhibits neurogenic inflammation and inhibits exaggerated pain signaling. These are the studies. This was published in New England Journal of Medicine in 2019, where it was compared with a placebo. Then in 2025, this is a phase 4 double-blind placebo trial, which says that where you have a triptan intolerability, you can use rimegepant. This is the operational terms for triptan unsuitability. So as far as rimegepant is concerned, there will be definitely a question that whether rimegepant is very readily available in the market. Yes, it is. However, you do require a neurologist's prescription for that. As of now, as I said, it is approved only for emergency or rescue medication. We do not have the approval for the prophylaxis management, but the day is not very far off where CGRP monologues will be allowed for prophylaxis management as well. Thank you.
Thank you. Hello. Hello.
Thank you, Dr. Novendu, for giving such an elaborate and explaining migraine in such a lucid way. That too, you had an interactive session with the audiences. I hope everybody has enriched their knowledge about migraine, headache, and you have removed a big headache by explaining headache so well. Thank you.
I'll request our chairpersons and our speaker to go to the memento section and collect their mementos. One more thing that Shorbanidhi has just told me, that one person will get only one memento. Maybe he or she may be chairing or being speaker in different sessions. So we move on to the next topic, that is medical negligence and relevant judgments. The speaker is Mr. Kaulol Bose, and the chairpersons are Dr. Mihir Chaudhary and Dr. Sudeshna Lahiri. I'll request the chairpersons and the speaker to come to the dais. And one more thing, that we have arranged for some water, tea, coffee on the right side of this auditorium. From time to time, one by one, you can go and have your drinks. But I'll request not to vacate the auditorium all at once.
Good morning, everybody. The present session is on medical negligence and the relevant judgments. After a few sessions on academic sessions, medical academic sessions, a slight deviation, but the topic is very interesting, especially for all the doctors, all the medical practitioners, that medical negligence is a very dreaded term. And the speaker, Mr. Kaulol Bose, Mr. Kaulol Bose, who is a advocate of Calcutta High Court, is the most qualified person to speak on the subject, that is medical negligence and the relevant judgment in this on this topic. So, time is 20 minutes. Huh? Mr. Bose,
Sufficient.
please. Thank you.
Good afternoon, ladies and gentlemen. Thank you for having me. I'm indebted to Dr. Guho, Dr. Kaushik Lahiri, Dr. Sudeshna Lahiri, and to all of you for inviting me to this session. I was wondering whether the hall is replete with the Bengali people or not. Dr. Lahiri assured me that yes, you can use bilingual language. So first, in this afternoon, in Bengali, গড়পাড় বলে এখানে একটা জায়গা ছিল, সেখানে একটা ছোট্ট স্কুল ছিল। সেই স্কুলে ষষ্ঠ শ্রেণীর ছাত্রদের জিজ্ঞাসা করা হয়েছিল, তোমরা যখন রাস্তা দিয়ে আসো তখন কোন গাড়িটা দেখতে ভালো লাগে? বিভিন্ন ছাত্র বিভিন্ন উত্তর দিয়েছিলেন। একটি ছেলে হঠাৎ করে উঠে দাঁড়িয়ে বলল, মাস্টারমশাই ট্রাম দেখতে ভালো লাগে। মাস্টারমশাই অবাক হয়ে জিজ্ঞাসা করলেন, ট্রাম কেন? বলল, স্যার ওটা একটা লাইন ধরে চলে। বড় হয়ে ছেলেটি এক আন্তর্জাতিক বাঙালি অন্তর্জাতির মধ্যে বিরাজ করেছিলেন, তার নাম সত্যজিৎ রায়, যিনি বলেছিলেন প্রতিদিনের রোজগারের তাগিদ আমাদের প্রতিদিন কাপুরুষ করে তোলে। সে এক শৃঙ্খলার কথা বলেছিল, যে শৃঙ্খল সভ্যতার কথা বলেছিল, এক সংযমের কথা বলেছিল। আইন This Consumer Protection Act 1986 was legislated by the Union Parliament. The Parliament was conscious of its time and they felt its necessity for implementation. The question is, who are the consumers under the Consumer Protection Act? Why the legislature thought it fit and proper to bring about certain amendments in the 2019? And what are the role of the courts, different courts, Consumer Court, Supreme Court of India, in deciding or adjudicating the disputes? We all know that law is a multidisciplinary subject, but despite this fact, law has not made a very unique friendship with the scientific arena. You all know that the climate of uncertainty in the arena of science, it gives us a wonderful thing, a thing like computer everything, because principle of uncertainty enriches the arena of science. একটি বিড়াল একই সময় জীবিত ও মৃত বা ঘূর্ণায়মান কণার গতি এবং তার অবস্থান একসাথে নির্ণয় করা যায় না, এটা কোনো বিজ্ঞানীকে যখন নোবেল প্রাইজ দেয়, on that score, in similar issue, if the law brings about uncertainty, it is anathema to the rule of law and it breaks the constitutional edifice, and we are at a loss how to implement the law. The Consumer Protection Act empowers the court to decide the dispute. Medical negligence is such a thing when the Supreme Court felt it necessary to delineate a line. In 1969 and 1989, Dr. Lakshman Balakrishna Joshi's case and A. Mittal case, the Supreme Court has laid down certain points. It is very difficult, even then I say, it is very difficult for us, the legal fraternity, to decide where is the actual factum of negligence without having any expert's opinion. Expert's opinion, it must come from the medical arena. Even then, the Supreme Court has tried its best. It says that it was laid down when a doctor is consulted by a patient, the doctor owes to this patient certain duties: duty of care in deciding whether to undertake the case, the duty of care in deciding what treatment to give, and duty of care in the administration of that treatment. Now the question is the infrastructural facilities and the relevant instruments, the relevant medicines, whether the hospital is having a sufficient number of all these instruments, all these facilities which are required for imparting treatment or administering medicines or the treatment to the patient. If that is not there, then what the doctor will do? Who will assess the helplessness of a medical professionals who is not assisted by a proper medical equipments, proper medicines, which are many a times it's felt is very necessary. It is the need of the hour. But this kind of infrastructural deficiency also made the doctor's position vulnerable, and many a times we lose sight, many a times we are oblivious of such kind of situation. We are unable, we fail to address this kind of issues, this factual matrix, when we bring certain cases into a curial combat. In law, negligence is defined as the deficiency to meet a standard of behavior authorized to protect society from irrational and unreasonable risk. It is a kind of a tortious liability, and it is a negligence which is a major consideration in the majority of cases involving personal harm and property damage. Consumer, now the definition of the consumer. The Act says, who are the consumers? A patient who avails service from a hospital or doctor and pays them consideration or fee for the services, any person who pays for the services availed by the patient, any person who is the heir or descendant of the patient, any person who is the parent or spouse of the patient. Now the question arises, if there is the consideration, if I don't pay any fees to the government doctors, if I am not under obligation to pay any fees to a doctor in a government hospital, whether I am a consumer? The answer is in affirmative. The Supreme Court says yes, and the Act says so. The medical negligence occurs when a healthcare provider deviates from the accepted practice, causing patient harm. Doctors have a fundamental duty of care towards patients, which may be enforced courts even without a traditional doctor-patient relationship. The three essential ingredients of medical negligence are duty of care owed to the patient, breach of duty, and harm resulting from the beach. The Supreme Court has emphasized in a landmark case of Pramanand Kartaria, wherein it has held that doctors must provide due expertise to safeguard life regardless of their workplace. I have confronted one situation, a radiologist who was transferred under the state government service from Kolkata to Malda. The doctor said that there is neither an X-ray machine, there is no infrastructural facility, but I have been transferred. It's a kind of a political vendetta or vengeance. I'm a victim of that, and I have to go to Malda where there is no such facilities. Initially, I obtained a stay. Ultimately, the court says the transfer is an incident of service, and you have to go there irrespective of the fact whether the radiology has any business over there or not. This is not for the court to assess. This is absolutely administrative domain. The administrative acumen must be tested on the anvil of the other constitutional parameters, rather the rational action. There must be an element of rational choice. The administrator must be a man who is not only prudent, but he should not be unmindful of his time and the climate. It is very difficult today. That is my little experience. I know very little of this, but while doing a case in court, I find that government hospitals, even private hospitals also, there are certain disadvantages and there are certain corruptions. And it is very difficult for the medical professionals to combat with this kind of thing, and which ultimately hampers their skills, their efficiency, because they are also human beings, they are working through the human agencies. And if the climate of intolerance, if the climate of corruptions are all deep and pervasive, then it does not allow a doctor to function in a way, because it demands not only a cerebral alacrity, but also a very, very careful mind. Because when I say it is a duty, because law does not define right. অধিকার কি? অধিকার আলোর মতো 7 সঙ্গের সমাহার নয়, 5টা শব্দের সমাহার। It says privilege, immunity, duty. ধরুন আপনি অনেক কিছু করতে পারেন, কিন্তু যা ইচ্ছা করতে পারেন না। এই যা ইচ্ছে করতে না পারার প্রিভিলেজটা আপনার নেই। আপনি একজন মন্ত্রী হতে পারেন, আপনি একজন বিচারক হতে পারেন। রাস্তা দিয়ে যখন গাড়ি চালিয়ে যাচ্ছেন, তখন আপনার লাল আলো ভাঙার ক্ষমতা থাকলেও আপনার কোনো মানুষকে চাপা দেওয়ার ক্ষমতা নেই। তাই জন্য বলা হয় যে আপনি অনেক কিছু পারলেও যা ইচ্ছে পারেন না। এই যা ইচ্ছে পারাটার মধ্যে রয়েছে আরবিট্রারিনেস, বাংলায় যাকে বলা হয় যাদৃচ্ছিকতা, which has been embodied in the Constitution, Article 14, which is one of the basic fundamental rights of the Constitution, guaranteed to the citizen of this country by the Constitution makers. কিন্তু দুঃখের বিষয় হচ্ছে এইটা, যে আমরা যখন এগুলো বিচার করতে যাই, আমরা অনেক কিছু আমাদের মাথা থেকে চলে যায়। আমাদের লড়াইটা হয়ে যায় অন্যরকম, কারণ আমরা ভুলে যাই জীবনের চলার পথে একটা লক্ষ্যের জন্য লড়াইটা লক্ষ্য হয় না। Action Act, particularly in Malay Kumar Ganguly and Shukumar Mukherjee, further included the concept of medical negligence. Very important. A renowned doctor of Calcutta, Dr. Shukumar Mukherjee, is one of the brightest minds of our time. I am nobody to assess his caliber, but he had to face a very difficult time. The Supreme Court, while awarding punishment and the tortious liability, it lays down certain principles which says that the concept of medical negligence establishing guidelines for determining liability, doctors cannot guarantee a cure, but must exercise reasonable care and competence. It says reasonable skill and knowledge are essential, not necessarily the highest degree. Adopting a treatment method with due caution and care is not negligence. Failure to diagnose with due care leading to wrong therapy constitutes negligence. It indicates the underlying principle is that your inability to foresee the basic minimum thing. It says that in Vinod Jain, the Supreme Court reinforced, it says that doctor's skill and care should be judged based on their ability to act as a competent professional in the given situation. It further says that this landmark case, that particularly the Supreme Court litigation, there has been the first grounds for litigation include, apart from your efficiency, apart from your inability to see the future event, because there must be a predictable journey, I will say the predictable trajectory, what would happen, একটা সম্ভাব্য গতিপথ, যে এটা হলে এটা হতে পারে। কিন্তু আমি একটা সাধারণ জিনিসকে দেখতে পেলাম না, এই সাধারণ জিনিসকে দেখতে না পাওয়ার অক্ষমতার ব্যর্থতাটা অপরাধ হয়ে ওঠে। That is the Supreme Court has said. Now, what are the other points which litigation include? Failure to issue receipt of bill to the patient, failure to take informed consent in the ambit of the unfair trade practice. Second, failure to maintain confidentiality, false endorsement of services or misleading advertisement product, service liability, and deficiency in services. The last encompass any act of negligence or omission or commission by such person which causes loss or injury to the consumer and deliberate withholding of relevant information by such person to consumer. Second, it says that in Balaram Prasad case, the medical negligence by doctor and private hospital, these judgments sparked debate how medical negligence compensation should be calculated. It says multiplier method, commonly used in motor accidents claim, was not suitable cases for death resulting from medical negligence because the two are fundamentally different in nature. One thing one must bear in mind that medical negligence, if there are two courses of treatment are available to a doctor, if the doctor has adopted another one course, the court is incompetent to decide the issue. The doctor must be allowed to scot free, and doctor should not be punished in any form, in any manner whatsoever. আমার কাছে দুরকম পদ্ধতি জানা আছে, আমি যে কোনো একটা পদ্ধতি করলাম। সুকুমার মুখার্জির মামলায় মলয় কুমার অনুরাধা শাহর মৃত্যুতে যে স্ট্যান্ডার্ড ইন্টারন্যাশনাল প্রোটোকল ছিল, the Supreme Court had applied its mind, and it was found that the standard protocol treatment was possibly not adhered to and resorted to. There were lapses, there were aberrations. Now, on this score, the punishment was awarded. Be that as it may, if there are two courses of treatment are available, if the doctor has resorted to the international form or the national standard, then the court is incompetent to decide the issue and to pass any kind of punishment in favor of the doctor, that is the law. There was a time when the doctor was easily could be implicated in a criminal case. After Jacob's case, the Supreme Court has taken a very firm stand that the criminal procedure code and the new law, the criminal law, that cannot be applied at the drop of the hats, and the doctor has been given an immense protection so far as the 304 of the old IPC Indian Penal Code was concerned. Now, it was argued that the care of the patient is also compromised by non-availability of infrastructure at the outset, I have said, which is the state's responsibility. Hence, the state to bears responsibility for lapses or deficiency in care. It may also be argued that it is hard to implement first world standards with a third world infrastructure. High rates of compensation may encourage defensive practice, affect the mental health of the doctors due to the constant fear of scrutiny, lead to their bankruptcy, and force them to spend time in legal proceedings, compromising patients, etc. একটা বাস্তবতা আছে যে বিভিন্ন পেশায় আমরা যেমন আমাদের সহকর্মীদের পছন্দ করতে পারি না, আমাদের প্রতিবেশী পছন্দ করতে পারি না, তেমনি সহকর্মী, আত্মীয় আর প্রতিবেশী ভালো হওয়াটা খুব ভাগ্যের ব্যাপার। হাসপাতাল বলুন, সরকারি হাসপাতাল বলুন, আদালত বলুন, সব জায়গায় আমাদের পেশার লোকেরা যদি আমাদের শত্রু হয়ে ওঠে, আমাদের প্রশাসনের জায়গাটা যদি আমাদের প্রতি সদয় না হয়, তাহলে বাইরের আক্রমণ থেকে রক্ষা করা খুব মুশকিল। কারণ একজন ডাক্তারকে যদি সবসময় যদি একটা অবজারভেশন, একটা সার্ভিলিয়েন্স, একটা ভয়ের মধ্যে থাকতে হয়, সেখানে সাহসী এক্সপেরিমেন্ট করাটা অনেক সময় বোধহয় হয়ে ওঠে না। আই ডোন্ট নো ইউ আর দ্য বেস্ট পারসনস টু টেল আস, বাট দিস ইজ অলসো ওয়ান অফ দ্য প্র্যাকটিক্যাল আসপেক্ট which the court cannot lose sight of it. Bolam test, that is one of the major and fundamental tests to determine the medical negligence. The Bolam test is widely used as a used standard for determining professional liability, particularly in medical negligence case. It assesses whether professional's actions meet the standard of an ordinary competent practitioner rather than the best in the field. This state acknowledges that multiple accepted methods may exist for a task and adherence to any of them is sufficient. The Bolam test is considered reasonable as it compares professional with ordinary competence, recognizing diversity in experience and skills, and avoids unfair comparison with the best practitioner. However, the test raises several questions such as who decides on accepted practice and how handling competing professionals' opinion and unaddressed risk, addressing inherent flaws in the professional practices, and dealing with practices contrary to public opinion. Additionally, it is unclear how to track professional expertise in chosen method and whether the test acts as an obstacle to innovation and improvisation of the profession. In Bolthio City versus Hackney Health Authority, the full disclosure to the patients, as in Roger Faker's test, these alternatives suggest potential improvements to the Bolam test, addressing concerns without stifling innovation and discouraging improvisation. In the Indian context, the Bolam test is widely applied in medical negligence, with the NCDRC, the Supreme Court relying on its various decisions. A critical analysis of the state's application in India is necessary to ensure it serves justice and promotes responsible medical practice. Ultimately, the Bolam test provides a reasonable standard for professional liability, but its limitation potential alternatives warrant careful consideration. The Bolam test principles are two key principles. A professional's actions are judged by the standard of an ordinary skilled person with similar expertise, not the highest expert skill. A doctor is not negligent if acting in accordance with a practice accepted by a responsible body of the medical professionals if another body disagrees, which is a very positive. And there are limitations deciding accepted practice, who determines accepted practice and how. Competing opinions, handling conflicting professional opinions or unaddressed risks, flaws in practice, addressing inherent flaws or defects in professional practices, public opinion, dealing with the practices contrary to widespread public opinion, expertise and innovation, tracking professionals' expertise and potential obstacles to innovation. Extended application concerns. The Bolam test application raises concern about stifling innovation, discouraging improvisation, and handling complex medical cases. The one thing one must remember, there is a risk in every curial combat. The law, it is a court of law, not a court of justice. That is what the American jurist said. Now, what is the difference between the law and justice? The law is a concrete idea. Justice is an expanded horizon of that particular idea. সেটা কিরকম? একটা অদ্ভুত ব্যাপার, একটি ছেলে, 5 জন ছেলে মিলে যখন একটি মেয়েকে নৃশংসভাবে সেদিন হত্যা করলো দিল্লির রাজপথে, তাদের প্রত্যেকের বয়স 18 বছরের নিচে। কিন্তু নৃশংস হত্যাকাণ্ডে তাদের বয়সের তাদের যে অভিঘাত, সেটা 21 বছর কেন 40 বছরকেও ছাড়িয়ে যায়। তাদের যখন ট্রায়াল শেষ হলো, because procrastination is an inherent disease of a legal system, and we are also responsible that we cannot attribute, সরকার জজ অ্যাপয়েন্ট করে না যাতে লোকে বিচার না পায়, সেটা সরকার করেই থাকে। যে সুপ্রিম কোর্ট নিজের জাজমেন্ট যখন ইমপ্লিমেন্ট করতে পারে না, যাদের জজ করার কথা ভাবে, তখন সরকার তাদের মতো করে জজ তৈরি করে, বিকজ টু অ্যাপয়েন্টমেন্ট অফ আ জাজ আলটিমেট হ্যাজ বিকাম আ পলিটিক্যাল চয়েস, এক্সিকিউটিভ চয়েস। সেই জন্য আমরা বিচারক করতে পারি না বলে ট্রায়াল দীর্ঘদিন চলে। একজন নারী যখন ধর্ষিত হয়ে খুন হয়, 15 বছরের ছেলেরা, 14 বছরের কিশোর অপরাধীরা নৃশংসভাবে তাকে যখন হত্যা করে, আর যখন বিচার শেষ হয় তখন 21 বছর, কিন্তু সেই বিচারটাকে ঠেলে দেওয়া হয়। আবার জুভেনাইল কোর্টে যে সাজাটা 3 বছরের হয়, কারণ কমিশন অফ অফেন্স অকার্ড when they were at the age of 15, 16 or 14। তাহলে কি হলো? আইন অনুযায়ী বিচারটা হলো, কিন্তু জাস্টিসটা হলো না। এখানেই ল অ্যান্ড জাস্টিসের কন্ট্রাডিকশনে আমাদের ফেলিওর, এবং এই ফেলিওরটা আমাদের ইনহেরেন্ট, কিন্তু আমাদের কিছু করার নেই। এবং এই যে ব্যর্থতাটা, একজন ডাক্তারকে শাস্তি দেওয়া হচ্ছে শুধুমাত্র পাবলিক ওপিনিয়ন বেস করে যদি করা হয়, সেখানে যে লোকটাকে শাস্তি দেওয়া হচ্ছে, sorry, thank you very much, but the conclusion is the only that ultimately that we have to, there are certain things, the healthcare fraud and medical negligence can be prevented through robust measures, implementing anti-fraud culture, everything. I'm extremely sorry for not being able to complete within the time. That is my failure, not attributable to anyone under the sun. Thank you very much for showing this patience. অনিশেষ কৃতজ্ঞতা এতক্ষণ আমাকে সহ্য করার জন্য।
Thank you, Mr. Basu. Basically, as they say, prevention is always better than cure. So though it might seem as a very, very remote topic for the clinicians, but still we all feel that clinicians should have the basic knowledge of medical legal aspects of healthcare. Thank you once again, Mr. Basu.
We come to the end of this session, medical negligence, and I'll request the speaker, Mr. Kollol Bosh, and our chairpersons, Dr. Mihir Chaudhuri and Dr. Sudeshna Lahiri, to kindly come on to the memento corner for receiving their mementos. The next session, another session on oration, Dr. Runa Mukherjee oration. The topic, topical steroid abuse in India, a silent epidemic of astronomical magnitude. The chairperson, Professor Dr. Piyush Kanti Dotto, and the speaker, Dr. Kaushik Lahiri. And I'll be requesting our chairperson, Dr. Piyush Kanti Dotto, to kindly come onto the stage.
So, very good morning, dear delegates and respected guests. This is a very important session, and on behalf of the organizers, I welcome you to this session. This topic is, as you know, this is an oration, and the name of the oration is Dr. Runa Mukherjee oration, which is going to be delivered by none other than Dr. Kaushik Lahiri. Two things I want to say. One is about the topic, steroid. Topical, particularly topical steroid, has revolutionized the dermatology. Initially, the ointments, lotions, cream, etc. was there. Then when steroid came, it has really revolutionized. But after it came, because of the abuse, not only by the doctors, but also by the patients, it will be. So that is a very interesting topics, and I before, as per customary, I will give a memento to Dr. Lahiri, and then I will ask him to present the oration. Actually, there is usually we give afterwards. So without wasting any time, I'll request, because it's a really a meeting which is running punctually. So please proceed.
Thank you, Piyush, as I always call him. Good morning. I think we have still 7 minutes in the morning session. And I really feel privileged to be here at the 50th Annual Scientific Conference and CME program of Eastern Railway Health Association, Health Service Association, and especially when the invitation was from the president himself of our IRHSA, BRSH, and the director, the medical director of B.R. Singh Hospital, Dr. Debashish Guho. Thank you very much for this kind invitation. And for the next 20 odd minutes, or maybe it may be a little longer, because what I know, my next speaker is absent. So I'll take this opportunity to utilize that as well. And I must tell you that some pictures will be little disturbing. And it's actually less on text and more on pictures. So the dermatologists, as you know, are very powerful, always. Like this man. This man thinks he is powerful, and we also think we are powerful. And but we don't beg for any prize or anything, not even for oration. We can turn black into white. We can turn white into black. Well, I'm discussing about skin disease, not money. We can grow hair. We can stop itch. We can do anything under the sun, but with a single weapon, not a mass destruction. এটা তো জং বাহাদুর রানার ছোড়া মনে হচ্ছে, সেই ফেলুদার গল্পটা মনে পড়ে। But that weapon is none other than steroid. So for dermatology, steroid ends with D and dermatology starts with D, right? So that is the basic impression about dermatology. Is it true? Is it false? Is it a good choice? Or it's a bad choice? Or is it something in between? Let us see. So what is the issue we are discussing? Now, the serious part of this is the issue. As Professor Piyush Kanti Datta and many other dermatologists in the hall, we face these unfortunate and sometimes horrendous faces every day, every hour in our clinic. And we really don't know what to do because nothing is written in our big textbook written by our Western counterparts. So the issue is topical steroid abuse, a silent epidemic of astronomical magnitude. I'll share a story of a crusade, a landmark movement in Indian dermatology. So the background is for non-dermatologists, unsupervised use of topical corticosteroid is a growing health concern in India. It's often used as a fairness cream or for minor skin issues without any prescription, and it leads to a condition known as topical steroid damaged or dependent phase, that is TSDF. The story of steroid goes like this. As you all know, the cholesterol started its journey from 1812, and skin disease was the classification in 1849, and many other developments. But our friend systemic, the topical steroid, was developed in 1951 when there was the first Asian Games in India and also the first general election in India after 4 years of our independence. So that's when the journey of topical steroid started about 74 years back. For non-dermatologists in the auditorium, there are some classification, potency ranking among the commonly used steroid from the superpotent to mildest. And the superpotent, we have this clobetasol or betamethasone or halobetazole, to potent like a fluticasone, to mildest like clobetasol or hydrocortisone. So it's good to remember that the clobetasol is actually the most potent topical corticosteroid, and clobetasone, which you can use in babies, is the least potent. So this is often confused amongst. So the therapeutic problems are frequently and inappropriately used on sites with thinner stratum corneum, injudicious prescription, indiscriminate OTC sale of topical corticosteroid, which is not available without prescription in any developed country, even in some underdeveloped country. Use of steroid as beauty creams leading to steroid dependence. So this is the national formulary of India. Now look at this. This is mometazone. It is a Schedule H drug. This is betamethasone. This is hydrocortisone. In India, it is Schedule H drug. Schedule H drug, as you know, not supposed to be available without prescription. Now, this is the Drug and Cosmetic Rules 2006. Look at this. Schedule H, the list of Schedule H, clobetasol, fluticasone, mometazone, we use every day. None of these drugs enlisted in Schedule H are supposed to be sold without prescription. But what happens in real world? This is the reality. The reality is this. These are sold freely all over the country without any prescription. This is somewhere in Latin America. They sell these arms without any license at all. And in India, we also sell. This is somewhere in Maharashtra. And this is like a gramer heart, jetake bole. All the medicines are being given. This is, I'm sorry, this is platform number 1, New Delhi railway station. Some very big shots from the railway are here. And the book stalls come chemist corner, available only the basic medicine which do not require medical practitioner as well, prescription. Now, our soldiers, we unearthed, now look at this. And we engaged the Minister of Health, Rail Ministry, and the available of basic medicine which do not require medical prescription at all. But all of these are available here. All these are steroid. This was clicked last week in Howrah Bardhaman main line local. Look at this. This gentleman, unfortunately, was selling Clobeta GM and Betnovet and everything. All the concoction of steroid at a reduced price as a hawker. This happens in India. So topical corticosteroid abuse on the face of prospective multi-center study. We did a study on 12 centers, including the most renowned, the government institutes to the armed force medical colleges. And the result was startling. The 60% was using topical corticosteroid face without any doctor's prescription. Mama, kaka, jatha, pishi, bariala, autowala, সবাই বলেছে লাগিয়ে গেছে. On the remainder, only 26.7% were using prescribed by a dermatologist. 82% of sale of topical drugs are actually steroid. And it is the total revenue generated is about 1,400 crore in 2013. Now it has crossed 2,200 crore in Indian currency. These are the commonest things that we all prescribe, like not only dermatologists, general practitioners, obstetricians, gynecologists, pediatricians, and physicians. A huge issue steps in. Now, look at the screen. Very unfortunate scenario. This is topical steroid dependent on damaged face. The topical steroid, this is our first paper on this topic. And sometimes I'm introduced that the next speaker is Dr. Kaushik Lahiri, who started topical corticosteroid abuse in India. With folded hand, I can tell I have not started topical steroid abuse in India. I just started the movement against it. And look at this faces. This is telangiectasia, not from any textbook, but from our patient. And he was applying Betnovet C as a aftershave cream. And look at this. Without any prescription, they were applying mother and daughter. And this luxurious growth of hair is also due to that. All these are now Melalong Plus, Tenovet, applying, because these are available without any prescription at all. So this is the mother applying, and you can see the wonderful hair growth. This is the daughter. And no scars. This is wonderful. No? Name is also no scars. And so we actually, from our association, we took the motto of naming and shaming all these brands. These are criminal brands. These are not available anywhere in the globe. And even the multinational companies are selling, which they don't do in the developed country. So these are happening on our hapless and unfortunate patients. They don't know what they're applying, but the manufacturers, they know it very well. And our drug controller, they also know how these are getting licenses. And she was applying the most potent topical corticosteroid to increase the glow factor. So you can see how the glow factor was increased in these patients. So this is not from Jupiter or Venus. This is from Mother Earth, unfortunate case, steroidectomy, and this is tinea faciae, hirsutism, and acne. So Indian obsession with fairness and whitening creams are the product of choice. Both Indian men and women are going for lighter tones and fairness product. যে কোনো ওই কন্যা চাই বিজ্ঞাপনে দেখবেন সেখানে কেউ কালো মেয়ে খোঁজে না, সবাই যেটা খোঁজে সেটা হচ্ছে গৌর বর্ণা, এবং সেটা করতে গিয়ে যেটা হয় সেটা হচ্ছে this was done by Morgan Stanley, and 46% of our consumer, they are actually purchasing a cream for fairness purpose, not for anti-aging, not for sunscreen, not for moisturizer, but for fairness. And the result is this, not only for, so unethical and unscientific combination, we strongly discourage all these things. Why the double and triple combinations are bad? Because patient gets relief in 1 to 3 days, the redness disappears, pain goes away. But what happens inside? The local immunity gets suppressed. Bacteria and fungus rapidly multiply because the body is unable to fight back. And so the first relief, relapse. And actually, the antifungal resistance is a huge problem. When 30 years back, we are postgraduate students, just কয়েক টাকার ওষুধে antifungal দিলে ওষুধ ছেড়ে যেত. Now, we are absolutely, Piyushda also will agree, whenever a patient of widespread tinea comes to ভয় পাই, because we don't know how to treat, and because the patient will come back again and again. So it is not an act of kindness. Do not prescribe all these medicines. It's misleading and it promotes drug resistance. It causes severe side effects on the skin and it leads to steroid addiction and irreparable damage to the skin. This clobetasol, halobetazole, betamethasone, mometazone, these are not to be applied on the face actually. And potent, super potent steroid combination creams have no role on treatment on any disease on the skin. What we can do? Over-the-counter sell of any steroid is actually illegal in India, but still going on. It's rampant. More sold without prescription than with explain the local chemist. We all always do. No steroid is needed in tinea infection. Our professors are regularly telling this. Here also, it's not needed. It's a simple case of impetigo. You don't need any steroid to treat this condition. This is a case of melasma. She was using all the steroid on face to get rid of her melasma, and this is the result. This is a case of herpes zoster, and she was using sarfagesen. That is a combination of beclomethasone, clotrimazole, and neomycin. Unfortunate. So I'll show you. This is 2.5-year-old kid, and he was prescribed Bitnovet GM 3 times daily for 30 days. So and what this, look at the eyes of this unfortunate child is applying Bitnovet GM. আমি যখন জিজ্ঞাসা করলাম মাকে কেন লাগাচ্ছেন, বললো বিটি ছাওয়া, বিয়া দিতে হবে বাবু. This is India. This is our country. And you don't know how to face this situation. This is not written in any textbook that how to face this situation in the clinic when the mother is telling বিয়ে দিতে হবে, আমার বিটি ছাওয়া তার গায়ের রংটা কালো. So they are using everything. And now look at some horrendous faces, no scars, and this Pandem Plus, Lobet GM. Whenever we see the names, whenever we hear the names, our blood boils. Quadridum, Betamil GM, Betnovet GM. Believe me, Betnovet GM is not available anywhere in the globe. It is produced by GSK, which is a global company. They are not allowed to produce Betnovet GM in US or in UK, but they can sell it here. Candidama, Sarfagesen. So I'll take another 5 minutes and it's 2 minutes. These are the unscientific cocktail products. Candid B, Jolef, Tenovet, Lobet GM, Pandem Plus, Sarfagesen. Just you can click a photo and do not ever prescribe all this. Otudam, Pentadam, Hexadam. And there is no need. So what we did, so this is the large body area involvement. We have never seen this kind of fungal infection when we were students. So look at this stage called GM, all this unfortunate. This boy got his first gift from her mother when he was 21-day old. Look at the loin of the mother and the inacanthus of this baby. This was a gift from the mother. So all are this fungal infection. So due to the steroid abuse, unfortunate steroid abuse. So what we did actually, now I'll show you. I think another 5 minutes I can take, Devashish, because the next speaker is not there. So because otherwise it will be, these are all, this kind of stretch marks and ulcerated stretch marks. We never had this in our clinical training days. And even from the Red Cross Society, in one prescription, one NIM, one Halosel S, one Mumosef, all three are potent steroid for one particular young adult of 19-year-old. No reason. Absolutely unethical. And I don't know why they are applying these on Quadridum, it's not exactly quadriderm. This is quitoderm. It looks like quadriderm. And applying on this baby. This particular boy we actually lost, unfortunately. He was applying Betnovet 1 tube on his body every day. Due to HPA access suppression, this boy ultimately died actually here in Kolkata. I'll not specify the name of the hospital, but we could not save this boy because of topical steroid abuse. Look at this. Look at this. This is horrendous. So what we did, approached the Honorable Minister of Health and Family Welfare 2006, Ambumani Ramadas. He was of my contemporary, 1989 outgoing MBBS. So he told me to get some real evidence, and we also started the Facebook page, and the petition started, and the task force was also formed. I was the first chairperson of IDWL task force. IDWL actually is the second largest global association of dermatologists with 14,000 members present. So all over India is a multilingual, multicultural country. All over India, we are thankful to the press and media, and our soldiers. We started working to sensitize not only general public, not only the local consumers, but also the chemists, the local shop, chemist shops, and our colleagues in dermatologists and non-dermatologists as well. So all over India, everywhere, we started to doing this. Even we were there in the Ministry of Health and Family Welfare. We met all the power corridor, and finally the director of drug health service, the GN Singh, the Drug Control General, came up with this very, very stern action, burning issue of topical corticosteroid use, and it was banned actually. So we were very happy. In 2016, it was banned, and we still continue with the walk and run all over India in all our conferences, and it is there in all the newspapers. And we took a pledge not to do this. This lady came all the way from Orlando and covered our crusade against this, and it was there in all the newspaper. And the first time in the world, a treatise on topical corticosteroid in dermatology was published by me. And the action was taken, the national outreach, the awareness campaign, the professional training, industry collaboration, retail regulation, government engagement, everything was done. And the reach was tremendous. I was awarded from the American Academy of Dermatology as well. And this is the first time that they're taking a hard look at the topical steroid. They did it. This was in 2018. The CNN Global, they also did a very big news on this. And finally, the impact was measurable. And the term TSDF is now recognized globally. National awakening is also there. Regulatory changes, thankfully, our national government has banned 328 irrational fixed drug combinations, and which include the 23 topical steroid branches, actually. The decline in dermatology prescription. And very recently, these are also there. These are the historic notification. And the government banned the 14 steroid products which contain this combination of all the illegal and unethical combination. So 2018, the 24 topical steroid containing combinations were banned. And the market impact was slow, but it happened definitely, as because this is a closed door. I'm sharing some slides. It's really, the impact was big on some big brands. I got some phone calls, the life-threatening phone calls, but that doesn't matter. And I was abused and trolled on social media by unnamed anonymous person, but it really nothing could touch me. The breaking news is just in April, the last, that is antifungal combination, was also banned by government. We are thankful to the national government for that. Our academic contribution continued, and very recently, the Royal College of Physicians in London, this was done in Liverpool, they also acknowledged our effort, and the Excellence in Patient Care Award, they selected us for that. And also, this was a huge appreciation from across from UK. And we have honored, and this was a global honor for us. The renowned our RCP Royal College, they honored us. So, but at this moment when we were taking this honor from them, at that very moment, another lady or another 100 of ladies, they were purchasing the same brand to apply on the skin of their baby to make them fair. So the take-home message is be aware and sure about the strength of the topical steroid before prescribing. There's no fairness cream on earth. And beware of the dramatic claims making fair within a week. Strong steroid creams should not be used on antifungal or antibiotic. Strong steroid creams should never be used either alone or in combination. And be careful on the area of the groin, axilla, face, use mild steroid. And in some areas like little potency, using of salicylic acid is acceptable, like in psoriasis in palmoplantar area. Hydrocortisone is not going to help there. And the weakest is clobetasone you can use in pediatric patient, and strongest is clobetasol or halobetazole, strictly not for pediatric patient. Do not use any mixed products with potent steroid on groin and axilla. Do not use potent, super potent steroid on face or around the eyes. Thank you very much. And without any doctor's advice, no steroid cream, make a pledge and stop steroid misuse. Like no landmine, that's a global movement. Like stop acid attacks, that's also global movement. Our movement is no more TSDF, no more topical steroid dependent face. Not everything that is faced can be changed, but nothing can be changed until it is faced. That is by James Arthur Baldwin. Let us join hands and drive this menace away. Thank you very much.
Thank you. Thank you, Kaushik, for the beautiful illustrated presentation. And thanks to the organizer for giving us this chance. Thank you.
So we come to the